Not yet now.
This meeting is being recorded.
Not yet now. I'm not able to see your video yet.
Um, 1 second.
Have you activated your video?
It's saying that I cannot uh, screen share while other participant is sharing actually, and
I can see your
my,
video now, but I cannot see
yes.
your presentation. Okay.
Okay, but I think somebody else is sharing still. They need
Okay.
to stop
Okay.
sharing.
Okay.
I can share my presentation.
All right. It's coming up. Yeah. Good.
You see my presentation?
Good. Yeah. Here you go. Yeah.
Yeah. A very good morning to all of you. And this is Dr. Savita here. I'm speaking from OncoStem Diagnostics, Bengaluru, India. And today I'll be talking to you about CanAssist Breast, a groundbreaking prognostic test for hormone receptor positive HER2 negative early breast cancer. We all know what are prognostic tests. These are the tests which help us to decide on whether to use chemotherapy or not. So in a patient who is diagnosed with hormone receptor positive HER2 negative early breast cancer, they typically undergo surgery where the primary breast carcinoma is removed, and they undergo prognostic testing. So typically the first generation prognostic tests here, like Oncotype DX and all, initially used to segregate the cases as low, intermediate, and high risk. But now practically all the tests, they usually segregate the test into these two buckets, which is low risk for recurrence, which are the cases which do not need chemotherapy, and high risk of recurrence. These are the cases which do need chemotherapy. And typically 70% of the cases are low risk for recurrence, and 30% are high risk for recurrence. Prognostic tests have been very popular, and just 1 second, please. Yeah. Prognostic tests have been very popular, especially in the West, where Oncotype DX and MammaPrint have been used for close to 15 years, and these are part of the treatment guidelines of their countries. They are included in NCCN, ESMO, NICE, ASCO International Treatment Guidelines, and also in the AJCC prognostic staging system. This has led to a widespread reduction in the use of chemotherapy in this category of patients, leading to improved quality of life for these patients. If we look at the differences between the breast cancer patients in Asian or Indian setup and Western setup, what we see is Asian breast cancer patients, they present much earlier. They are almost a decade earlier than the Western counterparts. They present with much larger tumors and many more node positive cases. These cases are largely symptomatic detection, and they present in stage 2. Whereas in the West, what we see are the smaller tumors. These are primarily screen detected. This is especially true because of the state-driven screening programs are very popular in the West, and these are predominantly presenting at stage 1. So what we see in Asian patients are patients presenting younger with more cases which are node positive grade 3 and higher Ki-67. So this requires a prognostic test which is able to cater to these requirements. So to deliver this unmet need, CanAssist Breast was developed. And CanAssist Breast and the story of OncoStem is 11 years old. It was started in 2011 by Dr. Manjari Bakre, a cell biologist with multiple awards under her belt. And it is unlike the other genomic tests. This is a proteomic classifier which works on the immunohistochemistry platform. So with 5 biomarkers, which I would be speaking about in more detail later, these which are critical markers in signaling pathways of tumor recurrence, these along with morphometric parameters like tumor grade, size, and node status, these are incorporated into a proprietary artificial intelligence-based machine learning statistical algorithm, and this generates a CanAssist Breast risk score. This score can range anything from 0 to 100 with a cutoff of 15.5. So any patient who scores 15.5 or less is categorized as low risk of breast cancer recurrence. This is typically around 70% of this patient, and these are the patients who can safely avoid chemotherapy. And the 30% of the patients are the high risk patients, and these are the patients who would benefit from chemotherapy. CanAssist has been validated on over 4,000 patients from India, US, and Europe. It has very high accuracy of more than 95%, with 95% and above negative predictive value, which is comparable to that of the Western test. Now here, I would like to say that this is at 1/5 of the cost. And the biomarkers which are used in CanAssist, the patent is granted up in many countries, India, US, China, Europe, Canada, and we have publications in several peer-reviewed scientific journals. The development of CanAssist breast was all this data which is coming in from the chosen biomarkers and the clinical parameters. They are put in a support vector machine-based algorithm, and the CanAssist risk score is derived. And this is published and available on Biomarker Insights. So coming to the role of CanAssist risk biomarkers, now I'd like to specify here that these are not the hormonal markers like ER/PR and HER2/neu or Ki-67. These are markers which are beyond this. This is very important because there is this question which is always asked whether this is ER/PR, HER2/neu, and Ki-67. It is not. So coming to the biomarkers which are used in CanAssist breast, these biomarkers play very important roles in all the events which are leading to the cancer progression. So cancer which starts in a duct, what is it that allows it to metastasize? It undergoes epithelial mesenchymal tract. There is a loss of cell-to-cell addition. There is dissociation of these cancer cells, which invades the bloodstream, which is a very hostile environment for this cancer cell. And they subsequently extravasate and undergoes again mesenchymal epithelial transition, in the process building up chemotherapy resistance, and forms a distant metastasis in bone marrow, brain, or say lungs. So now here it looks like a very simple process, but all this cancer signaling pathways, they are occurring in tandem, and at the same time it's a very complicated process. And CanAssist breast has identified these three very important steps, which is EMT, MET, and chemotherapy resistance, and the markers which are involved in this, and they're able to use this to get the CanAssist breast performance. CanAssist breast has been analytically validated, and as is with any laboratory-based test, now ours being immunohistochemistry-based test, we have followed the EGAP, CLSI, and the CAP guidelines and validated the test for various parameters, which includes tests of repeatability and reproducibility, looking at various things like intra-observer, intra-operator, intra-run. So all this shows that CanAssist breast is a very robust test, and we have also published validation of CanAssist breast on an automated platform. While this test was developed in India with the Indian population in mind, it was always the goal of Dr. Manjari and OncoStem Diagnostics to take this test across the globe. And to do this, we have done clinical validation extensively in over 4,000 patients in various reputed city centers across the globe. And these are our publications. This is our most recent publication, which is the publication of CanAssist breast in European early breast cancer cohort. This was done across 4 countries, Austria, Spain, Italy, and Germany. And this has shown that CanAssist breast is a robust test, and it works very well across different ethnicities. And it has shown its proven its utility as a prognostic test, which can help choose the right treatment modality for the patients. Now, before I start talking about the validation data, I'd like to briefly take you through the uh, process of CAN-assist based testing. This is what happens when the sample comes to the laboratory. The sample is received, it undergoes sectioning and H&E staining. It is looked at for tumor adequacy and other parameters, which I'll be speaking about a little bit in detail a little later. And subsequently, if required, ERPR HER2 is done for looking at the acceptability of the case, and then subsequently this undergoes IC testing for the CAB suite of biomarkers. Here, I'd like to specify that every CAB marker is accompanied by known quality control cases, and only upon the QC slide acceptance, test cases are evaluated. CAN-assist risk scoring is done by 3 trained independent pathologists, and subsequently this, along with the clinical parameters, is incorporated into the AIML algorithm, and prediction of risk score is done, and subsequently risk report generation and dispatch is done. This would interest the pathologists in the crowd. What do we pathologists do here? Here, first, when we get the H&A review, we look at the tumor content to see whether there is adequate tumor for actually doing the CAN-assist based testing. We look at histopathological grading and scoring. We also look for other interfering factors such as necrosis, sclerosis, hemorrhage, or suboptimal fixation. These are the parameters which could interfere with the test. And then we go on to identify the invasive tumor component in a very accurate manner. If needed, we mark the invasive component. We also look at the other internal controls and DCIS elements in the slide. And if multiple FFP blocks have been submitted, we look at the most representative block to do the testing. The next step is the immunohistochemical grading. It starts with the batch control review, which includes both the positive and the negative controls. Subsequently, we, on acceptance of that, we look at the test and first try to identify the internal control. This is how it is for ERPR also. So we look at the normal ducts and look for appropriate staining in these, and grading and percentage and intensity of invasive component is subsequently performed. CD44, ABCC4, ABCC11 are looked at membranous locations, and then pancadrine are looked at cytosolic locations. So the percentage of cells stained on membrane and cytoplasm, these could range from anything between 0 to 100. Average of scores after screening the entire slide of the entire invasive component is taken to give the final percentage value. Intensity of staining can also vary from 1 to 3, with 1 being the lightest and 3 being the darkest. Here I'd like to show you the few representative images of how high expression in membranous location could look like, and how low expression in membranous location could look like. As we can see in the upper panel here, it is easily identifiable, and the pathologists who report HER2 would easily identify this as looking somewhat similar to that. And in the lower panel, what we see here is the high expression in the cytoplasmic location, and we can very easily make out the low expression in the cytoplasmic location. As we all know, it is very important to fix the specimen properly for any, as it is for any predictive or prognostic marker. The same way, fixation plays a very important role. Prompt fixation within less than 1 hour of surgical resection in 10% neutral buffered formalin, and for a time period of 6 to 72 hours. Also, it is very important to make a note of the cold ischemia time, fixation time, and the fixative used in the TRF. Now we look at the actual CAN-assist breast validation data, and the validation data, and what we'll be largely seeing is Kaplan-Meier survival curves. So what are these? In the y-axis, what we see is this stent metastasis-free survival in percentage, and in the x-axis, what we see is time in months. So when we look at this entire cohort of patients who received chemoendocrine therapy, this is close to 2,500 patients. What we see is a very statistically significant segregation of patients into low and high risk. So almost 69% of the patients were segregated as CAN-assist low risk, which is this blue line here, and the DMFS is excellent at 95%. And the red line here, which is the high risk patient, around 31% of the patients were segregated as can assist, high risk, and these have a DMFS of 82%. And as we can see, the statistical separation the separation is statistically significant. When we look at the cohort of patients who received endocrine therapy alone, now this is a retrospective validation. We do not know for what reason the patients received only endocrine therapy. Perhaps because they were thought to be clinically low risk, or there were other comorbidities. But in this also, what we see is there is this 14% of patients who are identified as can assist high risk category, and they have a much worse DMFS at 85% as against the low risk category, which has a DMFS of 96%. So can assist risk has shown that the risk stratification has a negative predictive value of over 95%, and it is unaffected by the use of chemotherapy. Now, when we try to look at how can assist breast performs across different ages, now this is very important because, as I spoke, the Asian patients present in a younger age group. So, and actually, the most of the Western tests have been developed on postmenopausal women who are more than 50 years. So here, when we look at it in this light, what we see here is patients less than 50 years of age. Again, this is close to 800 patients. What we see is 70% of the patients have been identified as can assist breast low risk, and this is this blue line with DMFS of 93%, and can assist breast high risk as 30% of the patient with 79% DMFS. And again, this is statistically significant. And in age more than 50 years also, what we see is the same statistically significant separation is there, with almost similar proportion of cases being stratified as low and high risk. And as is expected, what we see is in less than 50 years, DMFS is slightly poorer than that in age more than 50 years. Sorry. Thus, can assist breast is able to stratify patients across age groups. Excuse me. Sorry. Now we look at can assist breast risk, how it performs in node positive and node negative patients. As I spoke earlier, we in Asia, we have much higher incidence of node positive cases. So we looked at and we did subgroup analysis of both the node negative and node positive. And what we discovered is the node negative cohort, which is this graph right here. What we see is, again, a statistically significant separation. Close to 1,500 patients were analyzed, of which 82% have been called as can assist low risk and 18% as high risk. And DMFS is significantly different, and at 96 and 88%. In the node positive cohort also, though the proportions are different here as is expected, 48% of the patients are called as can assist low risk, and they have an excellent DMFS at 93%, and high risk, 52% of these patients identified as high risk have a worse DMFS at 79%. Thus, it shows that can assist breast stratification is useful both in node negative and in node positive patients. And now we look at what is typically called as the clinically low risk category. These are the patients who, because of smaller tumors, node negative, low Ki67, these are the tumors which are categorized as low risk, and usually these are treated with endocrine therapy alone. Here, T1N0 tumors also, when we analyzed can assist risk scores in them, what we see is 7% of patients, even in this so-called clinically low risk, are identified as high risk. Now, these are the patients who would benefit with the addition of chemotherapy. Again, in T1, T2, N0 category also, 9% of patients are identified as can assist breast high risk category. Again, these are the patients who would benefit from chemotherapy. So can assist works in two ways. First, it helps us to identify the patients who are low risk and help them avoid chemotherapy. Also, it helps us to identify the high risk even in the clinically so-called low risk category. these are the patients who benefit from chemotherapy. So this helps us in personalizing, treatment in breast cancer patients. And to look at chemotherapy benefits, when we analyzed this subcohort of high-risk patients and low-risk patients, we looked at the data differently. We took this entire proportion of patients who were called as CANASIS risk, low risk, and we looked at what was the treatments given to them. Here, what we see here is this blue line. These are the patients who received chemoendocrine therapy, and this red line is the patients who receive only endocrine therapy. And when we look at the survival curves, what we see is this very superimposing line with, DMFS 96%, which is an excellent DMFS. And it basically indicates that in CANASIS breast low risk patients, whether they are treated with chemoendocrine therapy or with endocrine therapy, they show excellent survival. Whereas when we look at this graph here, these are the patients segregated by CANASIS breast as high risk. In this, when we look at the same treatment modalities, what we see, the patients who received chemoendocrine therapy in this subset of patients have done markedly better, almost 14% better than the patients who receive only endocrine therapy. This 14% difference between the options of treatment given here, this is what indicates the benefit of chemotherapy in the high risk patients. So do all prognostic tests behave in a similar manner across ethnicities and geographies? Now, to look at this, when we see some publications, what we see is mama print performs differently in Asian population as against the European population. Mama print typically in all the publications, whether coming from Europe or US, what we have seen is it gives a typical segregation of around 60% of the patients being categorized as low risk and 40% as high risk. Whereas these publications from Japan and Korea, which are present in this box here, what we see here is they have much higher proportion, around 80 to 86% of the patients being segregated as high risk, with only 20 and less than 15% of patients being called as low risk. Now, this should allow us to think that all this prognostic tests need to be examined in the intended population of use to find out the utility or usefulness of the test. Looking at the Oncotype DX data, and Oncotype DX data in the Black versus Black and non-Hispanic versus Hispanic patients, TAILOR-X trial, which was this beautiful trial with more than 10,000 patients, which was done at over 950 centers spread across North America and 2 centers in South America. The post hoc analysis, which was published by Kathy Albane et al., it showed that overall Black and non-Hispanic women had worse invasive disease-free survival, overall survival, distant recurrence-free interval compared to whites and Hispanics, as is evidenced by this much higher hazard ratios. So this triggered us to look at the performance of CANASIS test in various ethnicities. We looked at the Indian cohort, both the patients who received chemoendocrine therapy and endocrine therapy alone, and we compared how the CANASIS performed in Caucasian cohort. These are the patients who are primarily from the European studies, which is patients from Austria, Spain, Italy, Germany, and Netherlands. And what we see here is that the proportions have remained largely fairly similar to across the ethnicities and geographies, and CANASIS is significantly segregates the high and low risk category. Thus, CANASIS works very well in Indian and in Caucasian patients. Now we look at Chi-67 based stratification. Chi-67 is is used by many clinicians, even though there are many problems with it. There has been no clear agreement in the cutoffs. Now in the St. Gallen's 21, there was a recommendation. Even there was the cutoff was not agreed, but what it was agreed was less than 5% of the patients, less than 5% Chi-67 is low risk and does not need chemotherapy. More than 30% requires chemotherapy. But one of the most acceptable Chi-67 cutoffs has been less than 14%. And when we use that to segregate patients, what we see is, of course, it is able to segregate the patients, but less than 14% of the low risk category would be 54% of the patients are called as low risk, and DMFS is 93, and the high risk categories at 46% of the patients are called as are called as Chi-67 high risk, and the percentage difference between the DMFS is only 3%. Whereas the same patients, when they underwent Cancer testing, what we see is a much better and more accurate stratification. Firstly, the proportions are much better. So 77% of the patients are able to be segregated at low risk, and they have a much better DMFS at 95%, whereas 23% only are segregated as high risk, and they have a DMFS of 81%, and the segregation is statistically significant. So it works much better than Chi-67 in segregating the patient and with a much better negative predictive value. We'll very quickly look at luminal AB based risk stratification also, which is also one of the popular things that clinicians rely on to say, decide treatment modalities. When luminal AB based stratification is used, what we see is this: in this 972 patient cohort, 31% of the patients are identified as luminal A, which is the low risk, and 69% are identified as high risk. And though the stratification is fairly significant, the percentage difference between the DMFS is only 6%. Whereas the same patients, when they were tested with CanAssist, what we see is a 75% population which is identified as CanAssist low risk, and this has a much better DMFS at 95%, and 25% of the high risk patients have DMFS of 82%. So this is a 13% difference in the DMFS across the risk categories, and this again, it's a very statistically significant segregation. So when we want to compare CanAssist breast with the other multi-gene tests which are there in the market, we have done head-to-head comparison of CanAssist with Oncotype DX, and it is published in Cancer Medicine. And in that, what we see is negative predictive value of low-risk category of CanAssist breast was 93.4%, and this was comparable to that of ODX with TAILORx cutoffs. And this is looking at data from that publication. When we see CanAssist breast segregated 83% of the cohort as low risk, whereas Oncotype DX segregated 90% of the patients as low risk. And when the same patients who were called as low risk by CanAssist and Oncotype DX, they were compared. What we see is an 83% concordance between Oncotype DX and CanAssist. And also the negative predictive value is also very comparable to Oncotype DX. So, and this is at 1/5 the cost. Let us remember that. Now, I'd like to share the CanAssist with MammaPrint head-to-head comparisons. CanAssist called 67% of the cohort as low risk, and MammaPrint called 55% of the patient cohort as low risk. And when we see the same patients who are called as low risk between MammaPrint and CanAssist, we see 85% concordance between the same. Here, I'd like to bring Optima prime trial to view, in which many different prognostic tests were compared: ODX, MammaType, and ProSigna, and IHC4. And what they saw is that concordance between different prognostic tests was in the range of 40 to 60%, with a median of 47. So this goes on to show that CanAssist breast, has a much better concordance with these tests. How is CanAssist helping patients? CanAssist has been prescribed to over 300 doctors across 40 cities in India. We also received samples from Turkey, UAE, Sri Lanka, and Bangladesh, and over 2,000 patients have been tested prospectively till date. And 71% of these patients were classified as low risk of recurrence, and they could avoid chemotherapy, leading not only to savings but better quality of life. We have private and public reimbursement facilities also available. Now, here I'd like to share some of the clinical scenarios in which the clinicians face dilemma on how to treat these patients. There are these three patients I'd like to discuss about this. There's this first patient who's a young lady who was recently married and wished to have a baby. And there's the second patient who's a 36-year-old young lady who did not want to have chemotherapy. And the third patient is a 56-year-old lady who was again, hesitant about chemotherapy and its financial implications. All these patients were stage 2 breast cancers, and they had elevated Ki-67. And in a traditional setting, these are the patients who would be considered candidates for multimodal type of treatment, which includes surgery, followed by radiation, followed by chemotherapy, and subsequently hormone therapy. But here I am very happy to share that these are indeed patients which came to us in the first year of our commercial sales. This is the first patient who was 31-year-old and who wanted to have a baby. The clinician decided to do Canasis plus testing, and this patient was categorized as low risk, and this allowed the relieve the patient and the doctor to skip chemotherapy. This patient was given time to have her plan a pregnancy, have a baby, and after the delivery of the baby, she was put on endocrine therapy. This patient has finished 5 years of follow-up, and both the patient and the child are doing very fine. The second patient whom did not want chemotherapy again, and this patient on doctor's recommendation underwent Canasis testing, was stratified as low risk, and this allowed the patient to skip chemotherapy, and she's been on endocrine therapy, and at the end of 5 years, the patient is doing fine. This 56-year-old lady who was again hesitant about chemotherapy, both because of age and financial constraint, she also was categorized as low risk with Canasis breast testing. The doctors could safely skip chemotherapy and put her on endocrine therapy, and patient has finished 5 years of follow-up and is doing fine. So these are essentially success stories from Canasis, and this shows that the kind of impact Canasis breast can make on breast cancer patients. And this is a publication from India in which the Indian oncologists have shown that 92% of the Canasis breast low risk patients were not given chemotherapy, and 88% of the patients were either given or not given chemotherapy based on the Canasis risk score. Here I'd like to share what the oncologists in India think about Canasis breast. And this is a consortium of oncologists from premier institutes in India. They came up with this practical consensus recommendations for optimizing risk versus benefit of chemotherapy in hormone positive HER2 negative EBCs in India. Here they have recognized Canasis breast as the only test which is validated in Indian population, and they have included in their recommendation that Canasis breast low risk patient should be not given chemotherapy, and Canasis high risk patient should be given chemotherapy. Many oncologists have spoken about us in their publications and in media bites and mentions, in prominent magazines and very effective media mentions here. Also, oncologists in Turkey who have also used Canasis breast, they have also recognized that Canasis test helped their low risk patients to avoid chemotherapy and had an impact on their patients. ACE oncologists from India, Dr. S.P.S. Dev and Dr. Bapna, they have spoken in leading national conferences about Canasis breast and their experience of using Canasis breast, and it shows that Indian oncologists are adapting to Canasis breast in a very significant way. So why Canasis breast? Firstly, it has got multi-country validation. It's validated in Indian patients and in Caucasian patients. It is an affordable innovation. It is priced 4 to 5 times lower than that of the competitors. Other thing is it has cutting edge artificial intelligence, machine learning based algorithm at its core. And this is practically the only prognostic test which has any potential for drug development. And this is one area which is very exciting for us at OncoStem. Also, OncoStem Diagnostics is a very quality driven laboratory. We are CE marked and we have accreditation with ISO 13485, College of American Pathologists and NABL. And we have one of the fastest turnaround times with 7 to 8 days. This is just a summary of our Cannassist breast. It is a robust and cost-effective IC-based prognostic test for hormone receptor positive, HER2 negative early breast cancer. And it has proven that chemotherapy benefit is observed only in Cannassist high-risk patients. And over 83% concordance has been observed between Cannassist low risk and oncotype and mama print low risk categories, which is one of the best in the category. And Cannassist stratified patients much more accurately than Ki67 luminal AB classification and IHC4 based risk stratification. This I have not shared the data on this, but the data on this is available in our most recent European publication. This helps us prevent both under and over treatment of patients. Early data shows that Cannassist breast has saved 71% of patients from chemotherapy in a prospective manner in India till date. Patients treated based on Cannassist stratification have shown excellent outcomes post 5 years of follow-up. This has a multi-country validation, and Cannassist has shown that stratification is independent of cohort-specific differences, age, and node status. This is primarily because of the reason that it tumor biology over anatomy. So it looks at very key factors which look at tumor aggressiveness and helps us determine the high and low risk categories in a much more efficient way. This is just a summary of all our publications, patents, and regulatory approvals. This is our publications, and if you drop in your email ID in the chat box, I'll be very happy to share our publications with you. And last and not the least, a big thank you from all of us at OncoStem, and my email ID is here. You can connect with me for any collaborations or any queries. Thank you so much.
Thank you so much, Doctor, for the great presentation. Is there any questions from the audience?
Yes, please.
To ask from Doctor. Hello? Hello? Can you hear me?
I can hear you, sir. Yeah.
Okay. All right. Is there any questions for Dr. Savita from the audience? Dr. Savita, can I know how widely is this test being used in India, and is there any insurance coverage for that? Or
there is insurance coverage. There are a lot of
there is.
There are a lot of private insurance.
Great.
In fact, the CGHS and some government reimbursement of Cannassist breast is also it's also available.
That's great. Because that's, I think, great success in terms of risk stratification and prevention of excessive treatment like chemotherapy.
Absolutely.
With lots of
it would be wonderful to collaborate with you too, sir. Please share.
Okay. All right. Thank you so much. Thank you, Dr. Savita. Thanks for this nice presentation. Okay, I would like to introduce our next speaker, Dr. Damien Claret, I think, if I'm pronouncing correctly, from France.
Yes.
Dr. Claret.
Hello, I'm here.
Hello, hi. Could you please introduce yourself a bit and then share your presentation?
Yes, I try to share my presentation. Okay, can you see the presentation?
Yeah. Introduce yourself and start your presentation, please. Thank you.
Yes, I'm Damien Claret. I have a PhD in biology, and I'm a preclinical study director at Lattice Medical, a startup based at Lille in France. And this startup developed a medical device for soft tissue reconstruction, and more specifically for breast reconstruction. So again, hello everyone. Thank you for this introduction, and thank you for the committee for allowing me to present a result on breast reconstruction mediated using tissue engineering chambers. I start with a short introduction. In France, 1 woman in 10 develops a breast cancer. Each year, more than 50,000 cases are diagnosed, And this disease is the first cause of death by cancer in France. The main treatment option is partial or complete mastectomy, and current standards of breast reconstruction include different techniques, either prosthetic with the use of implant, or autologous with the free flap technique, or by lipofilling. These techniques all have advantages or disadvantages, such as the limited lifespan of silicone implant, for example, or the multiple interventions for lipofilling, or the sequels of the donor site for the flap technique. Therefore, at Lattice Medical, we are developing a new bioresorbable polymer breast prosthesis made by 3D printing. And this prosthesis is coupling with the pedicle fat flap breast reconstruction technique. So the principle of this tissue engineering chamber is to select a vascularized fat flap that will be inserted inside the tissue engineering chamber, and thereafter the tissue will grow and the chamber will be raised up to keep only the autologous tissue without a foreign body. This tissue engineering chamber, which we have called Matisse, allows the creation of a protective space around the flap, leading to the migration, proliferation, and differentiation of cells, and specifically adipocyte cells. The porosity of Matisse allows a high flow of growth factors and helps the establishment of angiogenesis. And finally, the presence of a 2D base prevents invagination of the underlying tissues. In this context, our objectives are various. We have already presented in part in the literature the safety and performance of the Mantis implant, but I will come back and complete this data. And now we want to go further by testing the compatibility of our implant with a radiotherapy treatment. To answer our question, we perform an in vivo study in 12 weeks old female Wistar rats. A third group was only implanted with the Matisse implant, so it's the control groups. A second group was irradiated locally for 3 weeks, 3 times a week, and then implanted with the Matisse implant. And third group was implanted and then irradiated with the same protocol of irradiation than the second group. The design of the study allows to mimic, in addition to a treatment by irradiation, the delay or immediate breast reconstruction that a patient could have. Because depending on the sequencing of radiation therapy occurring before or after breast reconstruction, occurrence of complication and clinical observation vary considerably. The animals were all implanted for a period of 6 months, and the growth of the fat flap was monitored by MRI every month from the 3rd month. On this slide, you can see the different steps of the Matisse implantation. So rats were anesthetized with inhaled isoflurane in combination with oxygen. Tissue engineering chambers were implanted subcutaneously in the rats in dorsolumbar regions. And the first step is a 4 centimeter incision performed under the lowest rib, as you can see in the pictures 1 and 2. After, subcutaneous fat flap was dissected by separating the subcutaneous fat of the skin. Then the size of the flap is standardized by using a mold with no volume in order to obtain reproducible data. The flap is then sutured to the base of the implant, and the shell is added, and the assembly implant, so shell and base, is implanted subcutaneously and fixed on the muscle. In this study, the implant use is similar on the one that could be used in women, but the size has been adapted for the rat model and measure 2.5 cubic centimeter. First, we focused on the physicochemical property of our implant after 6 months of implantations. Ex vivo, if you look the graph on the left, we note no significant difference in molecular mass between the irradiated and non-irradiated implant. And in the same way, the degradation in terms of deformation or resistance is similar in all groups. In fact, in an expected way, we observe a delamination of the 3D printing layer, leading to a deformation of the structure regardless of condition. In addition to the data presented in this slide, a recent study of DSC and GPC analysis have shown that the resorption kinetics are similar in all groups. So we can conclude that irradiation has no impact on the polymer degradation of the Matisse implant. During all the protocols, we follow up the animal and notice clinical observation, usually linked to in vivo studies in rats, such as self-mutilation and bites. We also noted several observations related to irradiation with the presence of depilation, erythema, or pruritus, without, however, being able to make real differences between the group 2 irradiated then implanted or the group 3 implanted then irradiated. As explained earlier in the presentation, the monitoring of the fat flap growth within the tech was performed by MRI, and you can see on the graph on the left that growth was observed in all groups, despite the fact that it was lower in the irradiated groups. The 3D reconstruction confirmed this slower growth of the fat flap in the irradiated groups. But despite this slow growth, we can still conclude that the Matisse implant is compatible with the growth of the fat flap inside the irradiation because no inhibition of this growth was noted. The hematoxin and eosin histological results show a variability of the quality of the tissue formed in the tissue engineering chamber when the implantation site is previously irradiated as in group 2, with in particular the presence of a higher quantity of fibrotic tissue and sometimes an abnormal morphology of the adipocyte, as you can see it on the histological image on the top right. This observation is not found in group 3, implanted and then irradiated. And we have been able to demonstrate that the tissue engineering chamber play a protective role and induces an attenuation of 10% of the radiation beam. So this information should be taken into account in our next study in order to adapt the real power of radiation delivered into the tissue engineering chamber. Then we focus more specifically on the quality of the adipocyte and show by perilipin and 4-HNE immunolabeling that the fat flap is formed of a mature adipocyte. However, in the result that you can see on the graph on the right, irradiating groups have higher mean adipocyte surface and lower adipocyte density, indicating a loss of progenitor cell subpopulation that regenerate adipose tissue and partially explain the slower growth of the flap. We also study cell death and tissue necrosis with CD68 immunostaining and did not visualize any specific labeling in the adipose tissue, proof of its good viability. On the other hand, and as expected, we observe a large quantity of macrophage in the connective tissue surrounding the flap as you can see on the image on the left. And this connective tissue is mostly located in contact with the polymer implant and is observed with or without irradiation protocol. Finally, we were interested in the vascularization of the fat flap, and as you can see on the image on the left obtained by immunofluorescence of CD31 staining, whatever the group, we have a good vascularization and angiogenesis of the fat flap. This observation is confirmed by the quantification of the vascular density, which show that whatever the zone of the flap analyzed, in the center, near the dome, or near the base, there was a good vascularization with or without of the radiotherapy protocol. Once again, this data confirms the good quality of the adipose tissue. So to conclude, we can say that Matisse mechanic property ensure efficiency of the fat flap growth. Tissue regenerating is highly variable and stable over time. The implant induces stability and less fibrotic response over time. And Matisse promote angiogenesis and cell proliferation with or without radiotherapy. So now to go further, we are moving to a larger model, which is mini-P, in order to confirm this result with a larger tissue engineering chambers. And the results obtained will be published in the next few months in the literature. And in parallel to these preclinical studies, biocompatibility tests are in progress in order to demonstrate the absence of cytotoxicity, sensitization, irritation, or also systemic toxicity effects in the short and long term. Thank you for your attention.
All right, thank you so much, Dr. Claret, for this great presentation. Is there any questions for Dr. Claret? Hello, any questions? You can post your questions to chat box anytime. Okay, so we'll return later. Okay, thank you very much, Doctor. Thanks.
Thank you.
Okay, now I would like to introduce our next presenter, Dr. Wafa Velieva from Azerbaijan. She will be presenting her poster about the main features of breast cancer in young women and modern approach in surgical treatment. Okay, Dr. Wafa, I'm passing the stage to you to deliver the speech. Could you please introduce yourself, please, and then share your presentation? Hello, Dr. Wafa. Can you hear me? Hello. Yeah, now we can see you. Okay, but we don't have your voice. Could you please unmute your voice, please? Okay, unmute and share your presentation. Hello, Doctor. Your video also stopped now. Hello. Okay, waiting for your video and your voice to be fixed, Dr. Wafa Velieva. I think there's some technical issues. All right. Shall we proceed with the next presentation? All right. I think. Hello.
Dr. Ali, I understand you. Is Dr.
Yes.
Feva available, or should I?
I think we can proceed for now, and then later on, we ask Dr. Wafa to present. Yeah, yeah. We'll proceed to the next presentation, which is mine. Yeah. Okay. All right.
Okay, so thank you, everybody. My name is Dr. Zama, and I'd like to introduce our next speaker, who has been chairing our conference so far, and his name is Dr. Ali Paul, and he'll be doing his talk shortly. Over to you, Dr. Ali.
Sure, I'll try to open my presentation. All right, can you see my screen now?
Yes, we can see you. Thank you very much.
All right, great. Thank you. Good. So now it's my turn. Actually, my name is Dr. Ali Mokhtarpour. I'm fellow of the Royal College of Pathologists of Australasia and now working in Iran in Noorspur Diagnostic Laboratory. So for now, for this time, I'm going to present a topic on the PD-L1 testing in breast cancer. So as you know, it's a topic of interest nowadays. Actually, PD-L1 is being tested on different kinds of tumors now, and there has been a great improvement in terms of the treatment of those PD-L1 positive cancers. So for this presentation, I'm going to talk about the recommendations and technical and histopathological issues of diagnostic PD-L1 assessment with an emphasis on invasive breast cancer, and we'll revise the current most relevant PD-L1 assays and scores, as well as recommendations for PD-L1 testing in breast cancer. So this is the schematic view of interaction of PD-L1 and PD-1 on different types of normal cells, as well as some tumor cells, which has been depicted here. So I will talk about this interaction in details later. All right, as you know, at the moment, there are lots of therapeutic modalities for invasive breast cancer, like conventional endocrine therapy, chemotherapy, and or targeted therapy, like, for example, anti-HER2 therapy, okay, Herceptin. And we have also some sort of targeting specific, actually specific oncogenes to be targeted, like CDK4/6 inhibitors. And the last one is actually immune checkpoint inhibitors, which is now being used widely in the world. Actually, it's a recent modality, which we will talk about actually a PD-L1 based treatment later, which is actually a member of this group. Okay, for the introduction, as you know, targeting the programmed DEF1 protein, or PD-1, and its ligand, the PD-L1, is the actually recommended standard therapy in many advanced or metastatic cancers nowadays. For example, like non-small cell lung cancer, urothelial carcinoma, Merkel cell carcinoma, classic Hodgkin lymphoma, head and neck and cutaneous SCCs, and also renal cell carcinoma. All right, in metastasized triple negative breast cancer, which is the topic of interest for today, those cancers showing a PD-L1 expression on tumor-associated immune cells actually showed the benefit of adding anti-PD-L1 therapy, which is now the most common one is atezolizumab, to nab-paclitaxel, and this addition showed better actually survival rate. Okay, so as compared to chemotherapy alone, addition of this ICI has been improved, has been actually shown, has showed actually better survival rate as compared to chemotherapy. So I'm going to talk about this, the axis of PD-1, PD-L1, and as immune checkpoint. Okay, so PD-1, what is PD-1? PD-1 is CD279, and it is a type of inhibitory co-receptor, which is normally expressed on the surface of T cells. The activation of PD-1 is through binding of its ligand PD-L1 or CD274, which is expressed on immune cells mainly. And this it causes self-tolerance or immune tolerance. So physiologically, the PD-1, PD-L1 axis protects us from excessive immune responses and autoimmune reactions. So this is the benefit of this, binding and ligands. Many solid and also some hematopoietic neoplasms express PD-L1 to inactivate the T cell response, and with that, somehow they escape the immune system or the immune response, and this is called in general immune escape. Okay, that's why those tumor cells can survive further and can actually progress and metastasize. So we have specific monoclonal antibodies, so-called immune checkpoint inhibitors. Okay, and these medications and these drugs are used against PD-1 or PD-L1, okay, either one, and suspend this inhibitory effect of PD-1, PD-L1 axis, and this leads to endogenous anti-tumoral immune response by T cells. So this is the benefit of using ICI or immune checkpoint inhibitors in this case. Okay, so you can see here, for example, this is a cancer cell. It's producing a PD-L1 like normal cells. All right, and this actually combination or binding of PD-1 and PD-L1 causes escaping from immune response, and this tumor cells can survive for actually longer. And using this anti-PD-L1 or anti-PD-1 treatment like atezolizumab, which was mentioned before, will inhibit this binding. Okay, and so the immune cells can recognize cancer cells as strangers and foreigners, and they can actually kill this type of cells. And with this, there will be like there will be like establishing the function of T cells to kill the tumor cells. So that's the mechanism of action for anti-PD-1 or PD-L1 treatment. So how this PD-L1 is being tested? So in routine diagnostic, PD-L1 expression is measured using IC. So most of the labs actually using immunohistochemical investigation for PD-L1. However, nowadays various commercially available assays and also numerous antibody clones for PD-L1 detection are available, as well as multiple expression scores and cutoffs. Okay, so we will talk about some later. So the thing is that the approval of immune checkpoint inhibitors often linked to a certain PD-L1 IC assay. All right, so for each type of treatment, we have to investigate specific type of also IC and specific clones, specific assays, and I will talk about this also later. So, and this is the reason why in a direct comparison of the predictive value of various IC antibody clones and also PD-L1 scores or cutoffs sometimes is actually compromised, and it's difficult to put in place. So studies performed to address this issue and also investigate the most reliable assays and antibody clones actually have been done, and still there is a need to compare the different staining and counting methods despite this fact, and the predictive values for immune checkpoint inhibitor response should be investigated, especially in breast cancer. Okay, so this table shows different types of PD-L1 IC assays and also antibody clones. You can see we have, as I said, different targets like PD-1, PD-L1, All right, and immune checkpoint inhibitors, based on different companies, they have different names. Okay, so we will talk about mainly atezolizumab from Roche company. So as you can see, each type of treatment has its own target, has its own pharmaceutical manufacturer, ISC detection system, or assay producer, or detection system or platform. Okay, and also different types of clones are being used. Okay, so like 28-A, 22C3, SP142, and SP263. Okay, so about staining and reporting. So what are the main points? So the clinician, first of all, should provide the pathologist with information about the intended immune checkpoint inhibitor therapy. Okay, so what kind of treatment is going to be used? And as the clinical trials that led to the approval of ICI are each associated with a specific so-called CIVD, ICSA, and particular score, as I previously mentioned. So what is CIVD? It's companion in vitro diagnostic, and based on FDA definition, it is a medical device which provides information that is essential for the safe and effective use of corresponding drug or biological product. Okay, so further about the preparation of IHC staining and also points about reporting, it is recommended that the whole slide section, approximately 4 micrometer thick, are cut from those best representative areas of the tumor, from the FFP tumor tissue, formalin fixed paraffin embedded tissue, just shortly before IHC. Okay, or else otherwise, if we cannot just use a fresh tissue, we can store just for no longer than a few weeks at room temperature. That's the optimum actually tissue preparation. So the PD-L1 IC staining protocol should be placed according to the assay manufacturer's recommendation. Okay, so that's the guideline. So the testing should contain an external positive control like any other IC testing. Yes, and the best one for PD-L1 staining is a tonsil tissue, which is a cost-effective type of tissue, and also is the alternative to PD-L1 positive cell lines. So further about tonsil. So normally tonsil contains PD-L1 positive immune cells and also epithelial cells. Okay, those epithelial cells, especially covering the crypts, they stain strongly with PD-L1, and also there are scattered immune cells which stain moderated to strongly with PD-L1. They can be scattered among the so-called germinal centers, or can be in clusters. And interestingly, the surface epithelium sometimes show no PD-L1 expression. So you can see the variation of staining and staining intensity in different parts of normal tonsil. So in the crypts, they stain strongly, and in the surface epithelium, there will be no staining, but normally the whole immune cells are stained in different intensity. So you can see it in this picture. For example, lining of the crypts shows strong staining, okay, epithelium, and just surrounding them, you can see germinal centers with patchy staining, granular staining, and paracortical areas also show just a minus staining, not that strong, maybe moderately to strongly staining of PD-L1. And interestingly, in the picture D, you can see there's no staining on the surface epithelium, and this is considered normal. Okay, so don't panic if you see just this kind of negative staining in your control tissue. This is quite normal, as opposed to epithelium lining the crypts. Okay, about neoplastic cells. Normally, neoplastic cells considered as PD-L1 positive if there is just membranous staining. Okay, so there has to be membranous staining of some sort. So it does not need to be complete or strong. It's just it can be partial membrane staining, also weak membrane staining. That's doesn't matter. So it's considered as positive. But for for immune cells, either granular cytoplasmic or membrane staining is fine. So it's considered as positive for them. Okay, apart from actually this is against neoplastic cells, which only considered as positive when there is cytoplasmic staining. Okay, so if there, membrane staining, if there is just cytoplasmic staining, but there is no membrane staining in tumor cells, that one is considered as PD-L1 negative. So that's very important for the pathologist assessing PD-L1. There has to be training, specific training in PD-L1 assessment, and also they have to participate in annual internal and external quality assurance. This is very, very important. They have to get updated. And the pathologist report should contain information about antibody clone used for IC, which is very important. Okay, the percentage of PD-L1 positive immune cells and also tumor cells, and the scores, different types of scores that we will talk about, also has to be mentioned, because these kind of scores are quite relevant to the specific type of treatment that you are going to use. Apart from them, the staining assay and platform also can be mentioned additionally. All right. So now I'm going to talk about specific PD-L1 scoring systems that we normally use in practice. So tumor cell score is the first one, defined as percentage of the area covered by PD-L1 positive tumor cells in relation to the whole tumor area. Tumor proportion score is the second one. Definition is the ratio of PD-L1 positive tumor cells relative to all vital tumor cells multiplied by 100. Okay, so this is just like proportion. It's like percentage of cells. Okay, in this picture, it's actually very a nice one. At this top left, you can see H&E, triple negative breast carcinoma, invasive, with lots of dysplasia surrounding the tumor cells. And picture B to D, there is PD-L1 positivity based on clone SP263. Okay, so a specific clone for PD-L1. And here you can see staining of both tumor cells. Okay, you can see this membrane is staining around tumor cells, and there are also intermingling inflammatory cells surrounding these tumor cells. All right, and those cells are also positive because they just show granular cytoplasmic or membrane staining of some sort, so they are considered as positive. Sorry, but for the picture E to F, you can see only granular staining of inflammatory cells, and those actually this type of tissue has been stained by clone SP142. Okay, so you cannot see any membrane staining of tumor cells, and that's why SP142 is very sensitive only for immune cells, not for tumor cells, as compared to SP263, which can stain actually both tumor cells and also inflammatory cells or immune cells. All right, so the next scoring system is about immune cells. So what type of immune cells are important? Intratumoral immune cells or a small pretumoral stromal rim of actually immune cells are considered for our calculation. So the method evaluates the percentage of the area occupied by all PD-L1 positive immune cells, all right, including lymphocytes and monocytes like dendritic cells, macrophages, as well as granulocytes. And this area is relative to the whole tumor area, and this is like again a proportion of cells. So that's how we calculate the immune cell score. And finally, we score them based on these numbers. Like score 0 is less than 1% of positivity. IC1 is 1 to 5%. IC2 5 to 10%, and more than 10% or equal to 10% is considered as IC3. So this shows actually immune cell scoring actually example for IC clone SP263. So you can see here low magnification, staining of germinal centers and the paracortical areas by this clone of actually antibody. And there are some intermingling neoplastic cells, as you can see here. They show just complete membrane staining. For IC score, this is very important that we should not count them to for calculating the IC score. So IC score means only immune cells has to be scored, and the immune cell has to investigate it. No tumor cells. So if you can see lots of tumor cells like this, so you have to actually just ignore them for your calculation. The next score is combined positive score. This score involves both tumor cells and intratumoral ICs or immune cells, or those in a narrow rim around the tumor. Okay, so we consider both tumor cells as well as immune cells, including lymphocytes, macrophages. Interestingly, neutrophil granulocytes here do not count. Okay, so we just ignore them. And the number of PD-L1 positive tumor cells and PD-L1 positive immune cells are summarized, and relative to the number of all vital tumor cells, they are just considered and then multiply, and this proportion is multiplied by 100. Okay, so again, we are just dealing with a percentage. Okay, how we are going to just use PD-L1 testing in breast cancer in detail, actually. So we have to know that combination of immune checkpoint inhibitor plus chemotherapy, as I previously mentioned, showed improved survival of patients. Okay, and this is confirmed by FDA and also EMA that we actually are able to use atezolizumab for the treatment. Okay, so atezolizumab is considered as immune checkpoint inhibitor. So this admission is again associated with detection of PD-L1 positive immune cells with an IC score of at least 1%. Okay, so we have to have at least 1% of positivity of immune cells in form of a positivity of IC score to engage those tumoral areas. So this is atezolizumab. You can see it, there's a vial with injection, actually with 60 milligram per milliliter of the actual so-called medicine drug. And this is produced by Roche company. Now this is widely being used. And there is in terms of investigation of the clones used for different types of treatment, the results show that the 22C3 clone and the SP263 identified other PD-L1 positive population, which is actually differing from SP142 results. Okay, so the results of 22C3 and SP263 are similar as opposed to SP142. And when we are dealing with a specific type of breast tissue, okay, and we consider this as a candidate for PD-L1 testing and respective treatment, we have to consider some facts or some things about the tissue or the procedure. First of all, we use this kind of treatment or this kind of testing for triple negative breast carcinoma or metastatic triple negative breast carcinoma. And normally they are candidate for atezolizumab plus nab-paclitaxel therapy. Okay, so we have to first filter those kind of tumor cells, or just pick those tumor cells as candidates of treatment. So there are some points about these types of tissues before we use or before we test and proceed with treatment. First of all, we have to take appropriate FFP tissue. PD-L1 IC-SC also matters. We have to consider the assessment of IC scores of triple negative breast carcinoma by a trained pathologist. And we have to engage in routine quality assurance, as I said. And also, it's better to harmonize PD-L1 IC-SCs as much as possible in invasive breast carcinoma. So for the FFP tissue, we can use both fresh tissues, okay, of primary invasive breast carcinoma or a metastatic one as well. So we have to try to use the most recent tissue. Okay, so the most recent tissue or the most fresh tissue is preferred. So biopsies, excisional specimens or surgical specimens also can be used. The point is that for those cytological material or decalcified bone metastases, so we cannot use PD-L1 SP142 because it's not validated. Okay, Ventana PD-L1 SP142 is not validated for those specimens. All right. About PD-L1 IC assay, so it depends on the respective drug approval. Okay, so I told you that we have a specific assay for a specific type of treatment. So in especially when we talk about specific country. Okay, so but overall, Ventana PD-L1 SP142 assay has to be applied. Except those decalcified bone metastases or cytological material. So this is recommended by US FDA. And the thing is that one of the drawbacks of this kind of assay is that the cost of commercially available PD-L1 assays are very high, and sometimes it's leading to a gap between costs of for the pathologist and also reimbursement. So this is one of the disadvantages of this test that we have to consider. All right, for the assessment of IC score, so the pathologist has to view at least 50 vital tumor cells and tumor-associated stroma. Okay, should be present. Okay, so tumor bed should be present, as well as at least 50 to 100 tumor cells, and the whole tumor area has to be evaluated, but we have to exclude necrotic areas. So the presence or absence of the distribution of the tumor-associated immune cells has to be investigated. Okay, controls also have to show adequate staining results. Means controls have to work before we proceed and before we finalize our results. Otherwise, the staining has to be repeated. Actually, when we are assessing a PD-L1 IC of especially triple-negative breast cancer slide, immune cells, including lymphocytes, dendritic cells, macrophages, and granulocytes, can be found either in clusters or singly dispersed, and that's fine. And we consider them as positive, as I said, when there is membranous or cytoplasmic granular staining. So again, the areas occupied by PD-L1 positive immune cells is recorded, and then it's related to the whole tumor area, actually a whole vital tumor area, and is considered as a percentage. So we exclude staining artifacts, necrosis, or intravascular immune cells. Okay, so we have to exclude all these things from our final scoring. So you can see varying IC scores. Picture A shows no scoring, no staining. So IC is 0, IC score is 0. B, you can see more staining of immune cells. It's about maybe less than 4%, but it's more than 1%. So it is considered as positive. Perhaps it's actually IC, we can consider as IC 1 or 2. And for picture C and D, you can see more extensive staining of PD-L1. It's about perhaps 25%. And so it's very, there is actually a high score and a strong staining. But you can see there are some tumor cells in between. You have to make sure that you exclude these tumor cells for your scoring. Okay, so you must not include these actually positive staining when you are calculating your IC scores. That's very important. So the thing is that the oncologists and pathologists have to be in a lively exchange, okay, in terms of calculation of IC score, and also which PD-L1 assay or laboratory developed test is being used, and which actually PD-L1 scores are required. So there has to be a close communication between pathologists and oncologists. So if there is unknown history of the patient or unknown prior or planned therapy, so you have to report, especially for solid tumors, you have to report ICSA or laboratory developed test that you are going to use, and also the antibody clone. Okay, the platform also can be added, as I said, and the percentage of PD-L1 positive immune cells and tumor cells and common scores, okay, have to be mentioned. These scores are related to the currently relevant or approved scoring method. Okay, so we have to talk to the oncologist that which type of medication or drugs is going to be used, and based on that we have to adjust our scoring system. Okay, so about the quality assurance, there is a strong recommendation for participation of pathologists in the specific type of treatments for PD-L1 assessment. So a specific training in PD-L1 assessment prior to implementing implementing it in routine diagnostic. Okay, so there has to be specific training and so-called experience. So for the internal quality assurance, rate of PD-L1 positive cases should be correlated with the result of clinical studies. Okay, and it's very important. And the fact is that prevalence of triple negative breast carcinoma with any type of with any kind of IC score, which is more than 1%, fluctuates normally between 32 and 86%. And this is depending on the assay is used. Okay, so for example, it's 41% for SP142. So participation in external quality assurance also is highly recommended. There are some organizations like Nordic Immunohistochemical Quality Control and the German Quality Assurance Initiative Pathology that are actually involved in this kind of quality assurance. So as I said, we have to try to harmonize the PD-L1 IC assays in routine practice. Okay, so there has been some studies like in a multi-center assay comparison study, moderate to high reproducibility and agreement of PD-L1 IC expression using the IC score in triple negative breast carcinomas was found between SP142, 22C3, and 28-8 assays. Okay, so they are similar in terms of the results, but the SP263 assay detected higher rates of PD-L1 positive immune cells as compared to the rest. Okay, so that's very important. So, but we have to try to harmonize the results and the assays, and try not to confuse with different types of clones and different types of assays. So, for example, in a study, again, 3 analyzed assays predicted improved the progression-free survival in the cohort treated with atezolizumab. So those clones are 22C3, SP263, and SP142. Okay, so they show improved progression-free survival in a group treated by atezolizumab. So definitely there are issues now with PD-L1 testing, because actually this test is just started the recent application, so there are lots of things to get improved. To date, there is no unique standardized method for PD-L1 evaluation. Okay, that's one point. And besides, several commercially available CIVD assays with specific defined antibody clones, platforms, and protocols, LDTs are widely used. Okay, so this is another problem. So just second, please. Okay. Another thing is that for each tumor entity, ICI or immune checkpoint inhibitor approval and associated assay and scoring methods are different. Okay, so that's another drawback of this kind of test. The approval of available ICI has been linked with specific CIVD assays and scores, as I previously mentioned many times, that we have actually each specific scoring system for different kinds of actually treatment modalities. Okay, so it's another, can consider another issue in terms of using this PD-L1 testing. So that's why actually each country or union has different admission requirements depending on the decision of respective agency evaluating the medicinal products. Okay, so it differs from one country to another. And the thing is that again, we have to emphasize on oncologists and pathologists close communication, and they have to update their knowledge and reconsider the procedure of PD-L1 assessment regularly. So apart from internal and external quality assurances, pathologists assessing PD-L1 ICSA should participate in tumor entity-specific PD-L1 evaluation event. Okay, so even for different kinds of tumors, there are some different types of training. This is to improve the inter-observer reproducibility. So what are actually the points that we need to consider for the future, or what are the further studies? What further studies needed for invasive breast carcinoma in the future, in recent future? So so first of all, we have to ascertain that which ICI improves the outcome of breast cancer patients. Which subtypes of invasive breast carcinoma, including triple negative, HER2 positive, or luminal one, respond to ICI therapy? Okay, so there are the questions now. Or in which setting, or either neoadjuvant or adjuvant, or also metastatic one, and also in which combination, chemotherapy alone or chemotherapy added to monotherapy, and in which sequence the ICI should be used. Okay, so there are some other questions. Which PD-L1 assay and which score predicts the response to ICI best? So this is another thing that has to be investigated. What is the extent of tumor heterogeneity, both within a tumor and also between a primary tumor and metastasis? This is another one. And whether digital image analysis may improve the predictive value of PD-L1 and increase the reproducibility. We are not sure yet, okay, about this. And then these are considered as actually the further areas for improvement, actually further investigation that has to be done in near future for to make sure that we are delivering the best service and best treatment to the patients. So take-home message, again, that PD-L1 testing is required for locally advanced triple negative breast carcinoma or metastatic one, which is intended, actually, which is planned for atezolizumab therapy. And PD-L1 IHC should be performed using adequate and validated assay, and also the assessment of PD-L1 positive immune cells using the ICS score must be reported by a trained pathologist. Okay, so the training is very important, and also experience. So continuous update of the level of expertise in this field, and also live exchange between oncologists and pathologists to optimize PD-L1 testing for breast cancer patients are very important as well. Okay, so that's all about my presentation. I would be happy if there is any question. Thank you very much for your attention.
Thank you very much, Dr. Ali. Very insightful presentation, and I think it was very well represented. So I'd like to invite anyone who has a question for Dr. Ali with regards to this subject matter. If you could just put them on the chat group or unmute yourself if you have a question for him. I wanted to find out, is the drug available in the state, or is it only available in a private sector? Because in South Africa, I know that they're still trying to introduce it in the States, but it's quite expensive.
Yeah, I think it's available now in the state. I'm not residing in the United States, but I know that now it's available in the United States and also in some other countries in Europe, like Germany, as far as I know, or Australia, if I'm not mistaken. But I'm not sure about the insurance coverage and all this. But I think that now is atezolizumab and some other drugs from different companies actually now is available. because it has got approval from FDA anyway.
Thank you. I don't see any questions, but I'm sure they'll be coming through later on.
Yep.
Thank you so much.
Okay, thank you, Doctor. So now, if there's no further questions, I would like to invite our next speaker, Dr. Valerie Duguid from United Kingdom, if I'm spelling correctly, Doctor.
Hi, that's
so yeah, please introduce yourself and share your presentation. Thank you very much.
surely. Well, thank you so much for inviting me to this event. It is a real honour, so thank you very much. So my name is Valerie Duguid. You're right, I am from the United Kingdom, and my talk today is really about cancer rehabilitation and prehabilitation, and I want to get the you know, the point across about the importance of cancer rehabilitation. Are we all still together? I'm just seeing me here. I take it we're all still here. Yes.
Hello, Doctor. I think we cannot see your presentation yet. Can you
No,
share
I'm
your
not.
presentation?
No, I'm not. I'm not sharing a presentation. I'm doing a talk on cancer rehabilitation and prehabilitation.
Oh, okay, okay, all right. Okay, no problem. Just go on, please.
Great, thank you. So yeah, so I wanted to open up really with what it means for an individual to have cancer rehabilitation, and then I'm going to be looking at our approach to cancer rehab here in the UK. I'm based in Scotland, in the United Kingdom, and then I want to look at what is going on worldwide with cancer rehab, and then I want to look at how as professionals we can be providing rehabilitation and how it can be included in our multidisciplinary approach. And then I want to look at prehabilitation, which is something very new. It's getting talked about recently over the last 2 years, but personally I've been providing prehabilitation, and I will discuss what that actually means. But I have been providing prehabilitation to people that have had a cancer diagnosis for about the last 17, 18 years. So without any further ado, so cancer rehabilitation, by the very term, what does that actually mean? So if someone has been given a cancer diagnosis and they have been through adjuvant treatment, so they've had various treatment forums, they've had possibly surgery, chemotherapy, radiotherapy, and then we are then left with that person and the side effects to the treatment. And the side effects can be very minimal in some people, and then they can be massively, massively extreme in others. But realistically, what does that look like? So you've got the physical situation where there is hair falling out potentially. You've got lethargy, you've got muscle weakness, you've got cognitive issues, you've got balance issues, you've got challenges with blisters on the inside of your mouth. What does that mean? It means that the person cannot eat and drink potentially. The side effects of that, you're going to have more lethargy, more muscle wastage. So usually by the time that I am working with, so I call them clients, I don't refer to people I work with as patients, but by the time I'm working with someone, it could be 6 to 12 months post treatment, and they have had no quality of life. They are tired, they are worried, every single pain, every single ache, there's a concern that the cancer has returned. They are not able to work, and they're not able to integrate back into what was their life before, and also having and trying to create a new norm is a challenge. And why is it a challenge? Well, I can only speak for me personally, and my experience is that the infrastructure post-treatment, there's still a lot of work to be done. So my involvement is purely from the physical and the psychological aspect. So I may be working with a woman who has had a breast implant. She may have had some surgery where they've used maybe latissimus dorsi. They've maybe used some of the abdominal muscle tissue for reconstruction. You've then got to work with that person on mobility. They've been sitting down for maybe 6, 9, 12 months. They are exhausted, they're petrified. So rehabilitation can be very, very slow, and it can be very minimal, because usually they are in such a heightened state of anxiety that even addressing and attempting to do some rehabilitation can be a real problem for many, many people. And I have rehabbed thousands of people in the last 17 to 18 years. So rehabilitation, from the way that I approach rehabilitation, is, you know, looking at their range of movement, possibly in the area where the surgery was, but also looking at their aerobic fitness, looking at their balance, looking at their cognitive abilities, and that is then providing a personal rehabilitation plan to that individual. Why? Well, we know that exercise in its entirety, especially post-cancer treatment, lots of evidence regarding you know, because of the effects on the immune system, that the chances of a secondary cancer is greatly reduced. But even talking about that to someone who is living with cancer or post-cancer, again, can be psychologically and emotionally traumatic. So a person, so I want to discuss, and I have this person's permission to discuss their rehabilitation with you. And this will just give you a little bit of an insight. So this woman that I worked with many years ago now, in fact, she was one of my first clients. She had breast cancer, she'd had her breast removed, there had been various attempts at implants, and her body just did not take well to the implant. So her surgeon was going to be using her gracilis muscle in order to construct a breast. But when I met the woman, she was getting told to lose weight for the surgery. So we had a bit of weight loss to manage. We had the psychology of the up and coming treatment and the post or the prior treatments that had not worked. So my focus was the weight loss, getting her aerobically fit, and how do we discover her general fitness? So we had to do essentially a fitness test. And where she fell short of all the normal parameters of aerobic fitness, of strength, of flexibility, we used those as guidelines. Well, why did we have to use those as guidelines in a sense? Because 17 years ago, no one was even considering cancer rehab. Certainly where I stay in Scotland, it was not a thing that was discussed. It was not a thing that was done, but I was doing it. So we looked at her aerobic capacity, and it fell way, way short of normal. So of a normal general fit woman of her age, her aerobic fitness fell short. Her strength, her fitness, her mobility were all short of normal parameters. So we used those as a gauge to work towards for her up and coming treatment. And then I had a conversation with the surgeon about, I'm going to do a lot of leg work, as in working on gracilis, so exercises that would build her gracilis muscle so that it would improve the you know, the chances of the surgeon having a real healthy, meaty, well oxygenated, well formed gracilis muscle so that would help the procedure, the surgery. And the surgeon at the time was really, really open to this, because at the time, as I say, it wasn't well received. And he was so open to this approach. And he said, you know, I really, really like your thinking. Now, the long and the short of it was, this surgery was a success. So in my mind, we were doing rehabilitation from before. We were then doing prehab, and prehab was getting this woman ready for the up and coming treatment. We had to get weight off, we had to get her into better physical condition, better psychological condition. And then there was the focus on the gracilis muscle itself, so that the surgeon would have something to use in the surgery. And I then went on to work with her post that operation, because I hadn't worked with her before. We worked together long after in order to at rehabilitation. Now, I briefly touched on prehab, and over the last few years, I've seen various, you know, studies, etc., and you know, on LinkedIn and various conferences that I'm involved in, and it's as if prehabilitation is a new thing. It's not necessarily new, but it is certainly needing a lot more focus. And prehabilitation, again, is just as the name suggests. When I meet someone who has been given a cancer diagnosis, generally that person has a level of health and fitness that is usually, they would be classed as being deconditioned. So what we're attempting to do is to improve their conditioning, just as I spoke about the previous client. We are looking at improving their all over fitness and their all over conditioning, because we know that treatment is better received, and we know that post-treatment, the horrendous side effects of cancer treatment, they are addressed in a sense with being prehabilitated, being fitter, being stronger, being healthier, and we know that the outcomes are better. But I just want to speak about what in actual fact prehabilitation is, and it is just very, very similar to what I was discussing before. You would take the general health and fitness parameters, so you would take someone's cardiovascular fitness as it is just now, allay it with where it should be, and then you attempt to improve each and every aspect of their fitness. Why? Because you want them to be in the best physical condition prior to going in for treatment or for surgery. Why? Because the afterwards, the after effects of the treatment and the surgery, we know have been positively affected by the health and the fitness of that individual. So from the work that I do here in Scotland is working with clients on a day-to-day basis, both in rehabilitation and prehabilitation, and trying to raise the awareness of the importance of that person's general fitness prior to surgery. Now, there are various countries around the world that are better at this, and I think that we can be working with professionals all around the world to, you know, have a scheme, have a plan in place, because we know the outcome of the treatment. And yes, treatments are becoming, you know, less aggressive. We know all of that, but nevertheless, until that is common for everyone that is experiencing cancer, then there is a mismanagement, or can be a mismanagement of treatment and therefore recovery. So exercise may be something that is frowned upon because it is not well recognized, or it's not well known how exercise, etc., can benefit cancer, and even with other medical professionals. So having these events, having these conferences that allows the topic to be aired and discussed and you know, look to be provided in a multidisciplinary team for the improvement of cancer services around the world. So I don't know if there's any questions or any comments. I'm happy to elaborate if it's needed. I'm happy to answer any personal questions.
Thank you so much, Dr. Valerie, for the nice presentation. I would like to invite the audience to ask the questions. If there is any question, please ask Dr. Valerie. Any questions from the audience? Okay, thank you so much, Doctor. Thanks. You can post your questions to the chat box anytime, and we'll revert to your questions later. All right. I think Dr. Sorry, just a second. All right, Dr. Wafa. Hello, Doctor. Dr. Wafa Valiava. Are you ready now? I think still we cannot hear you. Can you unmute your speaker? We are not able to hear you, Doctor. We can see your video, but cannot hear you. Can you unmute your microphone? I think down left bottom. No, it's still we cannot hear you. Perhaps this the problem still exists. Okay. I think we can, if team doesn't mind, we can proceed to the next speaker. Okay. Dr. Huria Belkaralati from Algeria. Dr. Huria, are you online? Are you ready for the next presentation? Okay, I think Dr. Huria also is not available now. All right. What about Dr. Linda Khan from USA? Dr. Linda, can we proceed with your presentation? All right. Okay, so we have to have a few minutes of break till we connect with other speakers. Okay, so perhaps 10 minutes. Okay, can you please let me know how many minutes or how much time do we have for the break, please? Okay, so let's go back in 10 minutes. We try to resume our connection with other presenters. All right. Thank you, everyone. Okay. Hello. Can you hear me? Dr. Huria Belkaraladi from Algeria. Are you ready to present your topic? Hello. We cannot see you, and also we cannot hear you, doctor. Okay, so seems that Dr. Huria is ready to talk about her presentation, but we are not yet able to see her video, and also, okay, now, good. Dr. Huria, can you unmute yourself? Hello, Dr. Huria. Can you hear me? Hello, doctor. Can you hear me, Dr. Huria?
Yes, but yes.
You can hear me?
Hello.
Okay.
Hello.
Yes. Yeah.
But
We have your video.
I didn't found the presentation.
I see.
How to share it, please?
There is a sharing button. So down, there's a green button. Okay. Yeah. Somebody is sharing for you. Okay. Good. So now we can see your presentation.
Thank you. Hello, everyone. It's my great pleasure to present you my presentation, mucinous carcinoma of the breast, morphological and immunohistochemical study of 13 cases. These are introduction. Breast mucinous carcinoma is a rare histological variant. It's characterized by the production of mucin extracellular and represents 2% of all breast cancer. The aim of this work is to analyze the morphological characteristic, immunohistochemical, and establish histoprognostic factor of BMC. Method. We conducted a retrospective study of 13 cases of BMC collected in the lab, in our lab of pathological and cytology of CHU Sidi Bel Abbès over a period of 8 years from January 2012 to December 2020. During this period, 850 cases of breast cancer have been diagnosed. We have found 13 cases of BMC. These cases have been reviewed and analyzed by taking the data reporting and assessing the age of patient, the type of surgical procedure, the pure or mixed histological type, size tumor, the histological grade according to SBR, PTM stage, hormone receptor, HER2, and Ki67. Results of our study. During the study period, 13 cases of BMC were diagnosed, which represent 1.5% of all breast carcinoma. BMC was pure in 8 cases and mixed in 5 cases. All of our patients were female. The patients were aged between 33 to 76 years, with an average of 51 years old. On macroscopic examination, the tumor was soft and gelatinous in appearance. The average tumor size was 4 centimeters. Microscopy of right mastectomy of the tumor cut surface with a gelatinous substance and little fibrous tissue, which gave a colloid appearance of the tumor. On histological examination, 8 cases, 73% were diagnosed as pure mucinous carcinoma with a large area of mucus, in which bat epithelial cells arranged in cluster with inconsubstantial cytonuclear atypia. 5 cases were classified as mucid mixed with foci of ductal carcinoma and situ. Histologically, abundant extracellular mucin contain malignant epithelium as glandular structure or individual tumor cells, including signaturing cells. These tumors were grade 1 in 8 cases and grade 2 in 5 cases. Average tumor size was 3 centimeters for grade 1 and 4.5 centimeters for grade 2. The lymph node status was N0 in 8 cases, N1 in 4 cases, and 2 in 1 cases. No extranodal metastases in all cases were detected. In the immunohistochemicals, study 9 cases express intensely the hormone receptor, which represents 63%, and only 4 cases, 25%, were positive for HER2 and negativity for Ki67 on the 11 cases. Immunohistochemistry, nuclear expression for ER and PR. And immunohistochemistry, negativity for HER2. For discussion, BMC were first described in 1826 by Gister. The BMC accounts for approximately 2% of all breast carcinoma. As in our series, it was 1.5%. The age range is wide with any average age of 60 years old, which correspond to data reported by our study. Clinically, BMC often present as well as definite, mobile, and benign lesion lobulated. The tumor size is varied from 1 to 20 centimeters with average of 2.8 centimeters. It was 4 in our study. There is no significant relationship between tumor size and the grade, as well as tumor size and lymph node metastasis. This is related to the great amount of mucus occupying the answer tumor. Breast mucosa represents for many authors the different stage of pathological continuum proceeding of BMC. Macroscopically, BMC appear as well subscribing tumor of soft consistency lobulated with a shiny gelatinous appearance and grayish color. Histologically, BMC is characterized by a proliferation of uniform cells nest with sparse eosinophil cytoplasm bathed in pools of mucin separated by small fibrosepta. These cells nest vary in size and shape, sometimes taking on a rarely papillary tubular arrangement. Cytonuclear atypia and mitosis, as well as microcalcification, are rare. 5% of cases. It was 36 in our study. The significant proposition of differentiation neuroendocrine is detected by immunohistochemistry, chromogranin, and synaptophysin. Pure BMC is composed entirely of mucin carcinoma. It can be cellular and hypocellular. The term cellular has been used by some authors to differentiate the variant endocrine of BMC from non-endocrine one. The mixed BMC, whose most important component frequently associated is invasive ductal carcinoma. The differential diagnosis arises with a myxoid fibroadenoma and mucocell by the presence of epithelial and myoepithelial cells in the mucus. Immunohistochemistry often shows 50 to 80% hormone receptor positivity cases. In our study, it was 63%. The expression of HER2 is often negative. It was 27%. The antibody is considered pejorative. Histoprognostic factor, however, the expression of BCL2 is correlated with a good prognosis, not made in our study. The prognosis of poor BMC is good compared to mixed BMC. In conclusion, BMC shows fewer metastases, lymph node, a strong expression of hormone receptor, a low level of expression of HER2, and a good prognosis compared to non-mucinous carcinoma of the breast. Thank you for attention. And sorry for
thank you so much.
Okay,
thank you so much, Dr. Huria. Thanks for your presentation. It was great and informative. Actually, I would like to invite participants. If there's any question, please ask Dr. Huria. Ask about the topic of mucinous carcinoma of the breast, morphological and immunohistochemical study of 13 cases. Any further questions? Okay, if there is no more questions, thank you again, Dr. Huria.
Thank you.
And thanks for the presentation.
Thank you. Sorry, I'm sorry. Thank you.
No problem. It may happen sometimes. Okay, no problem. All right, Dr. Wafa, are you online? Can you proceed with your presentation now?
Yeah.
Okay, great. We can hear you now. Great, great. Yeah. Okay. Could you please share your presentation, and before you start, introduce yourself, please? Thank you.
Thank you. I'm Dr. Wafa. I want.
Yeah, Dr. Wafa, please share your presentation. We cannot see your presentation now.
Okay, where are my posters?
No, not yet.
Not
Have
yet.
you shared your screen? Okay, good.
Okay.
Yeah, you can go on now.
Okay. I want to talk about the main features of breast cancer in young women and modern approach in surgical treatment. Risk factors: family history, genetic mutation, BRCA1, BRCA2, radiation therapy of the chest or mammary gland, and epidemic factors. Do you hear me? Everything okay?
Yes, yes, it is. Yes. Yeah.
You see me? Because I don't see.
You can just proceed. We can see your slides now. No problem.
Main features diagnosis is more difficult in young women. Male aggressive forms of the tumor are observed. Axilla positive in more common. Chemotherapy and radiotherapy are read. Drugs that suppress ovarian function are used in hormone and pulse forms. Multifocal, multicentric forms are very common. Main symptoms: tumor in the breast, skin changes, local pain, and pulled in nipples. Main examination, main symptoms I said, and now examinations methods, please. Palpation, ultrasonography, mammography, MRI, and true-cut biopsy. Examination methods. Basic treatment methods: surgical, chemotherapy, radiotherapy, endocrine therapy, and immunotherapy. Surgical methods: breast conserving surgery, oncoplastic operations, nipple and skin sparing mastectomy, and always sentinel lymph node biopsy. Histological forms: invasive ductal carcinoma, invasive lobular carcinoma, and DCIS. Histochemistry: luminal A, luminal B type, hair positive, and triple negative types. Main points in surgical treatments: location of the tumor, volume of the breast, shape of the breast, the size of the lesion, and morphological changes. Main indications for choosing a treatment method: tumor size, lymph node status, histological grade, hormonal receptor status, HER2 new status, and histological type of tumor. Always before we do true-cut biopsy in all patients, and before the neoadjuvant therapy, as a poster, please, as a poster. Before the neoadjuvant therapy, we put into the tumor stereotactic marking clips, and into operation, to be sure radicalism of operation, we do specimenography. In young patients, where most of the time we do breast conserving surgery, different types of oncoplastic surgery. In this patient, 31 years old, after 8 course chemotherapy, we do rocket mammoplasty. In these patients, also young patients, 28 years old, and hair-positive patients, after 8 course neoadjuvant chemotherapy, we do nipple-sparing mastectomy with implant reconstruction, subpectoral implant, with subpectoral implant, mentor. And we do different types of breast conserving surgery. All these patients is young patients, and we do breast conserving surgery, all of them. And we, in all patients, we do sentinel lymph node biopsy. And if necessary, in these patients with tumorectomy, we do reduction mammoplasty. And last patient is a different patient, 16 years old with multiple fibroadenoma, and I took out approximately 40 fibroadenoma in this patient with round block Benelli technique. Thank you for attention.
All right, thank you very much, Dr. Wafa. for the poster presentation. If there's any questions, we would be happy to get your questions. Any question from Dr. Wafa about this poster presentation? Okay, thank you so much, Doctor. Seems there's no more question for now. So anytime you can post your questions to your chat box. I think we will have a break. We are a bit ahead of time, so we will have a break until I think 1:40, if I'm not mistaken. So we will be back after that to continue our sessions. Okay.
Hello.
Okay.
Hello, can you hear me?
Yes, I can.
Good.
Perfectly.
Sorry.
Yeah.
Sorry, just to, I just want to touch base. Am I introducing Dr. Thomas? Oh, sorry, it's Linda.
Yeah, Linda Ann Khan.
Okay. Oh, I see. Okay. Sorry, just 1 minute. Okay. So good afternoon, everybody. Are we ready to start now? Can we do the introductions? Okay, my next guest is Linda, who's going to be addressing us on the lymphedema subject. And I'd like you, Linda, to get ready to share your talk. I don't know if you're ready with your talk. I'm just going to step out and then we'll allow you in to share. Thank you. Yes, you can see the screen.
Okay, you're good?
Yes, yeah, thank you.
Okay. Thank you. Do you want me to start?
Yes, please. I think we're ready. We've got 21 candidates already.
Thank you so much. Well, good morning, good evening, wherever you are. It's very early here. My name is Linda Ann Khan. I am a certified lymphedema therapist. I live in San Diego, California, and I own a clinic here, have several lymphedema therapists working for me. We work with a lot of breast cancer patients, and unfortunately, there are so many of the patients who do have lymphedema. I've been practicing for over 30 years. I graduated at the Dr. Vada School in Austria and the Dr. Foldy Clinic in Germany. And I also trained at the University of Australia in Adelaide doing lymphedema therapy. So, whoops, what happened? Oh, there we go. Sorry. Let's go over there. Sorry, it's not going forward for some reason. My screen is not going forward. I don't know why it's not moving, so I am going to just have to do it that way. I'm going to very, very briefly go through different breast cancer. I'm sure we've already covered a lot of it, so I'll just go really quickly through it. But breast cancer is one of the top 2 causes of cancer deaths, together with lung cancer in most developed countries. And 99% of breast cancers do occur in women, with 1% in women. I have worked with several breast cancer patients in men, and the incidence increases with age. Breast cancer is rare under those under the age of 30, but presents up to more 1 in 14 women over the age of 40. I am actually seeing more breast cancer in younger people over the last years. I don't know if this is attributed to the large amount of hormones that we have in our food and in our air and all over. 15 to 30% of breast cancers are in situ, and 75% are the invasive type, while ductal carcinoma is the most common, making up to 80% of all breast cancers. Breast cancer is the most common type of cancer in American women, with the exception of skin cancer, and it accounts for 1 in 3 cancers diagnosed in women. There are many types of breast cancer, as I mentioned: ductal carcinoma in situ, invasive ductal carcinoma, tubular carcinoma of the breast, and inflammatory breast cancer. The ductal carcinoma in situ, the cells that line the milk ducts of the breast have cancerous changes, but the cancer cells have not spread throughout the walls of the duct, and it's considered non-invasive or pre-invasive breast cancer. Different hospitals do different treatments for cancer, and the treatments have changed so much over the years since I graduated in 1992. And as we're going to talk about, there's a lot of lymphedema saving surgeries that are taking place. And I'll speak to you about some new advances too. Lumpectomy following radiation treatment is typically what's done here in the US as a treatment for ductal cancer in situ. And the lumpectomy is called breast conserving because most of the breast is saved. And it can appear on mammogram at microcalcifications. According to the American Cancer Society, about 60% cases of ductal cancer in situ are diagnosed in the year. It's known the invasive ductal carcinoma is an infiltrating ductal carcinoma, and the cancer that's begun growing in the milk duct and has invaded the fibrous or fatty tissue of the breast outside of the duct. And surgery is usually the first treatment for invasive ductal carcinoma. It will either be a mastectomy or a lumpectomy or axillary dissection. We now have the sentinel node biopsy over the last 15 years or so, which removes only the first 1 or 3 of lymph nodes in the lymphatic chain. This has really helped to reduce the incidence of lymphedema very much. And I'm seeing less and less axillary dissection taking place as we have more sentinel node biopsy. When I first was practicing, it would be common for patients to have 20 and 30 nodes removed, sometimes all of the chains removed. So it's definitely been a more of a lymph sparing. And then if the tumor has spread, then they do treatments such as chemotherapy or hormonal therapy. We're seeing a lot of immunotherapy now as well. Inflammatory breast cancer is rare and very aggressive. The symptoms begin to appear when the lymph vessels become blocked and the breast becomes large, aching, and red. The nodes are swollen. I had a patient present to me with this condition. It had been, I can't believe it, but it had been missed at the hospital. And she indeed did have inflammatory breast cancer, which was really, really sad. And here's the invasive metastatic breast cancer too. And then I'm not sure what you guys have covered here, but we do have hormone receptor positive or negative. And they have different treatments depending whether it is HER2 positive or HER2 negative. And triple negative, if it does not express these other HER2 or PR, then it's called triple negative. Inflammatory breast cancer is often triple negative. I've worked with a number of patients with triple negative. And my goal always in working with the patients is to help them to reduce the risk of getting lymphedema. And we're going to talk about lymphedema now. Treatment for this will be hormonal therapy or selective estrogen receptor modulators such as tamoxifen, or there are other medications that are used, and then aromatase inhibitors, which reduce the estrogen. These have a lot of side effects, and some of the patients can't tolerate them. Surgical removal of breast cancer aims to control the total disease through removal of the primary breast tumor, along with any local excision. Breast conserving surgery or lumpectomy and axillary dissection is often done. When that is done, they will then do radiation with it. And so the axillary dissection refers to the removal of the lymph nodes in the axilla. Recently, I had a patient who had 30 nodes removed, which is very, very unusual. So it had to have been a really aggressive cancer if the doctor had done that. Because now we are seeing the sentinel node biopsy, which is amazing. And so what they do is they inject a blue dye into the tumor site, and then the blue dye will move and it goes to the sentinel node or the first node. It will identify that first axillary node. And usually less than 6 nodes are removed, but the way this works is they will inject the dye, and if the first node is not cancerous, they don't have to remove any more, but usually they will remove another 2 or 3 nodes. If it's cancerous, they'll continue until the node is not cancerous, and then maybe take out several more as well. So it's less aggressive, and it's used with less aggressive invasive disease or with a prophylactic mastectomy. They'll do the sentinel node biopsy to check to see if the lymph nodes have been involved. If there's less risk of arm edema, but the breast can be higher, lymphedema in the breast. There's less scarring, and there's reduced shoulder and arm mobility, and a much, much faster recovery. So it reduces the risk of lymphedema really, really very, very high. However, once radiation is performed, that again will increase the risk of lymphedema. The axillary node dissection, which, as I said, I'm seeing less and less of this. They will remove lymph nodes. Level 1 would be inferior to and lateral to the pec minor. Level 2 would be deep to the pec minor. And level 3 of nodes would be superior to and medial to the pec minor. Typically, only levels 1 and 2 are dissected, and I do not see that a lot. I remember seeing a study not that long ago. They might be not doing the axillary node that much anymore. This is something very new and wonderful that is being done called axillary reverse mapping, or ARM. So a blue dye is injected into the upper arm to visualize the axillary nodes that they want to avoid during sentinel lymph node biopsy. A radioactive tracer goes into the breast to identify the sentinel nodes in the breast. And by doing this, there are less nodes that need to be removed. And 40% of the nodes with sentinel node biopsy were identified were in the surgical field. And 80% of the nodes identified with the axillary lymph node dissection will visualize the nodes and remove less of the nodes that actually drain the arm. The goal being we want to reduce the risk of lymphedema. So we need to talk about the lymphatic system, because this is what is key, is what we're working on when we're doing all of these treatments. And the lymph system is part of the immune system, and it's a network of lymph vessels and lymph nodes running throughout the entire body. And the lymph system transports disease-fighting cells and fluids. And there are these nodes, which are in clusters. They act as filters for carrying abnormal cells away from the healthy tissue. So I work on the lymphatic system every single day. In a healthy patient, we would go in the direction of lymph flow. In a patient with lymphedema of the arm, or who've had axillary lymph node dissection, or is at risk of getting lymphedema, and we'll be talking about the stages in a little while, I would then go, I don't know if you can see my arrow here, but we would move from the affected side across the chest to the unaffected side. We would drain the fluids. Or we would go from the axillary, the affected side, and we would go down to the inguinal nodes to redirect the fluids away from the affected area. With the lymph system, the thymus is involved, the tonsils, the spleen, and of course the bone marrow. Starling's principle was something that was known for hundreds of years. And we now have a revised Starling's principle. And what we used to believe with the Starling principle was that the fluids were removed from the vessels into the connective tissue. And then once everything had been processed in the tissue, 90% of the fluids would go back into the bloodstream. And 10% of the fluids which were not able to go back into the bloodstream, which included the proteins, long-chain fatty acids, toxic hormones, and anything else toxic in the system, would be picked up by the lymphatic system. And we called that the lymph obligatory load. But Doctors Peter Mortimer and Dr. Roxon and his team in 2014 discovered new information And they discovered that there is something called a glycocalyx, which is on the endothelial layer of the blood vessels. And what happens is this glycocalyx disrupts the oncotic pressure gradient, which would allow the fluids to return to the bloodstream. And so now we have found that 97% of the fluids that are in the connective tissue are now returned to the lymphatic system. And once it goes from the interstitial tissue into the initial lymph vessels, it is now called lymph. So Starling's principle has been revised. I always knew how important the lymphatic system was. Now we know that it is even more important than anything else. In fact, we are now saying that all edema is lymphedema. And just going back to this little diagram over here, so the lymphatic system originates in the connective tissue with these little initial lymph vessels. It then moves into the system, into the bloodstream, and goes into the supraclavicular fossa, just above the clavicle, and the lymph fluids enter at that point into the bloodstream. And from there, it goes to the heart, to the lungs, back to the heart, and then it is eliminated via the kidneys. And lymph travels in a set direction, going to each lymph node station where the nodes are, that it's filtered through, and then continues to the next node station. So when I do my lymphatic drainage on the patients, I am observing normal pathways, or if someone who's had breast cancer or ovarian cancer or other cancers where there's been nodes removed or radiation, I will then work to other areas which we call the lymphatomes. So it's a very important part of our immune system, and it's responsible for removing wastes. It's made up of all these lymph vessels and lymph nodes. It's become even more important to keep our lymphatic system boosted now during these COVID times. According to the World Health Organization, lymphedema affects over 250 million people worldwide. And despite this, the research evaluating the lymph system and the effectiveness of treatment has been very scarce. Too many patients are left undiagnosed and untreated and suffer unnecessary pain and suffering. Right now, we have the Lymphedema Treatment Act going through Parliament, and we're hoping that finally, after 7 years, it will be passed so that there can be more help for lymphedema patients. So what is lymphedema? It's an abnormal level of fluid accumulation in specific areas of the body, causing swelling and discomfort. There's no cure, although that is changing now with all the new surgeries that are taking place. It can be managed through a multi-pronged approach. Lymphedema can be primary and inherited. These are the old systems, Milroy's, Precox, and Tada, although we now have new divisions that we have, because now there's all gene therapy that's taking place for primary lymphedema. But secondary lymphedema, which is from trauma or blockage to the lymph system, is a result of breast cancer surgery, which is what we're talking about, or other surgeries, and of course, radiation. 5+ million people in the USA will experience some level of lymphedema after breast cancer surgery, which is much more than MS, multiple sclerosis, Parkinson's, and other diseases. There are different stages of lymphedema. There actually is a stage 0. My professor, late Professor Foldy, of the Foldy Clinic in Germany, actually brought out a stage 0, which as soon as there has been surgery and or radiation, the patient is now at risk for getting lymphedema. So we call that stage 0, which is subclinical or latent. There is no swelling present at that time, but there is a lifelong risk of getting swelling due to surgery because of radiation or injury to the lymphatic system. They could have a mild tingling. When patients come to me, if I get them in early stages, I can palpate. I've been doing this for so long, my fingers can palpate and I can feel differences in the tissue and then instruct the patient what to do to reduce the risk of getting lymphedema. Stage 1, lymphedema is reversible. It's mild. It resolves with elevation. It may have soft pitching, but usually not. And there's no fibrosis or tissue changes at that stage. It is reversible at this stage. There have been no permanent skin changes that have taken place. And then stage 2, the ISL, the International Society of Lymphology, has made stages 2A and 2B, 2A being spontaneously irreversible, and lymph elevation alone rarely reduces the swelling and pitching is present at this point. And then stage 2B, it may or not pit and fibrosis starts to appear there. The lymph volume increases, their skin folds can occur, and the tissue can become harder as fibrosis can continue to occur. Fibrosis is the collagen that is laying down to protect the body as a result of inflammation. There can be infections, and that is the main risk of cellulitis or erysipelas, as they say in Europe. And volume reduction can occur with proper treatment, and we'll be talking about that treatment in a little while. And then stage 3, we're starting to get more into more skin changes and infection. So breast cancer related lymphedema is a particular form of secondary lymphedema occurring after axillary surgery procedures and or irradiation. It represents an important morbidity which jeopardizes the breast cancer patient's quality of life. Patients will tell me that they got through the breast cancer. It was really debilitating. It was terrible. It was so sad. And they got over the shock and they've accepted that they had breast cancer. And suddenly lymphedema occurs. And many of the patients have told me that the lymphedema is worse than the cancer. Of course, we know it's not, but to the patient, that is how it feels. And it's also a constant reminder of their cancer. The edema can be several inches larger than the other arm or even more. I see a lot of patients in early stages, and I can help them prevent them from becoming later stages. This is a very exciting surgery called lymphatic microsurgical preventative healing approach, which is taking place a little more. We have a doctor here in San Diego who worked in Paris for many years doing this surgery, and he's now at one of the hospitals here in San Diego. It's a very innovative microsurgical technique where blocked lymphatic vessels are drained into the blood circulation, creating a shunt between a lymphatic channel and a blood vessel, and creating this lymphatic venous bypass. The lymph procedure is performed at the time of the planned axillary dissection surgery for the prevention or to reduce the risk greatly of upper extremity lymphedema. And what they do is the patient, they put in a patented blue dye into the patient about 10 minutes before the skin incision. This will allow for mapping of the lymphatic channels to identify for the bypass. And the node dissection is then performed with preservation of the anterior branch of the axillary vein in the axilla. Afferent lymphatic vessels will be sutured into a branch of the axillary vein distal to a competent valve, respectively. And the total duration of the surgery is approximately 3 hours, which accounts for about an extra 30 minutes to the standard axillary node dissection. This is a study that was done from July 2008 to 2012 with 74 patients who underwent axillary node dissection for breast cancer treatment together with the lymph procedure. They did volumetry pre-operatively and afterwards 1, 3, 6, and 12 months to monitor what was happening. Lymphoscintigraphy was performed in 45 patients and 30 post-operatively until at least over a year 71 patients had no sign of lymphedema, and the volumetry was coincident to preoperative conditions. In 3 patients, lymphedema did occur 8 to 12 months postoperatively, and the lymphoscintigraphy showed the patency of lymphatic venous anastomosis at 1 to 4 years after the surgery. So this represents a successful surgical procedure for primary prevention of arm lymphedema in breast cancer patients. So I'm hoping that this will be done more and more. We also now have Indocine in green, which can visualize everything that is happening in the lymphatics. Symptoms of lymphedema involve swelling and possible discomfort, and the skin and the underlying tissues are affected. They become at risk for infection, and it becomes very difficult to fit for clothes. A lot of depression can fit in to the patients. So the role of therapist is really being a coach, helping the patient, educating the patient, and really helping them to deal with their disease. This is a patient of mine who has come several times and doesn't take care of herself. And she doesn't come for 2 years and then comes back and it's worse. Not my ideal patient. What increases the risk of developing arm lymphedema following breast cancer? The axillary node dissection. There's 2.5 times more likely to develop lymphedema, and especially if there has been axillary radiotherapy radiation, that will double the risk. A mastectomy doubles the risk of developing arm lymphedema, and obesity, there is a 50% increase in the risk of developing lymphedema with obesity. And then with chemotherapy, it increases the risk as well. So there are things that are under the patient's control, but other things that are not. A lot of patients do seem to put on weight after breast cancer surgery. So I work with them very closely with their nutrition and exercise to help them with that. Here's some other pictures. This is a patient before and after therapy. And then radiation can cause burns and scar tissue, and the patients can be very overwhelmed. So we really have to look at psychosocial issues as well and how the patient is functioning in their life. Many patients have to stop work depending on what type of work that they're doing. And so the challenges to the breast cancer patient are many. Muscular radiation burns, which restricts the range of motion, and it's painful. Mucositis as they're going through the chemotherapy, hair loss, scar tissue, fatigue, reconstruction scars and pain, lymphedema, which is what we're speaking about, depression and anxiety, and neuropathy secondary to chemotherapy. Challenges also the muscular stiffness, so we have to do range of motion exercises, help them with their posture to accommodate pain or discomfort to try and prevent the arm frozen shoulder, and the accompanying muscle tension restricts the flow of lymph. Yesterday we had a physician in the clinic who came in for some treatment himself, and he actually works with breast cancer patients. He does shoulder surgeries and orthopedic surgery, working with the patients who actually developed frozen shoulder. So that's what our goal always is to avoid, to help with the skin contractures and with the scars, as their range of motion can be affected from all of the scars. And so we gently massage. What can also happen as a result of the breast cancer surgery that we see and can work on with our lymphatic massage, you can develop axillary web syndrome or cording as a side effect to the sentinel node surgery. And you can see the cording there. It sometimes can spread all the way down to the elbow and all the way down. I've seen it sometimes even down to the hand and then onto the chest wall. So the trauma from surgery against the connective tissue can cause this inflammation and the scar tissue, which develops alongside the lymphatic vessels and blood vessels and nerves. We used to pop the node, but then now we're thinking it's more of a lymphatic node. And so we stretch it and massage it. and work on the fibers causing that have caused, we work on the connective tissue that have caused the cords to form. It's painful. It restricts range of motion. And so we can work with a laser. I work with a low-level laser to actually help with the cording and soften it. We also do cross-fiber work and teach the patient what to do at home. I'm consulting with somebody actually via Zoom, and she has terrible cording all the way down to her wrist. And so I have advised her to see a therapist in her area. So the treatment of lymphedema is what we call complex decongestive therapy. And there are two phases to it, phase 1 and phase 2. So phase 1 is what is done in the clinic or in the hospital, and it's called complex decongestive therapy. We do the manual lymph drainage to stimulate the flow of lymph. We will work away from the affected area onto the contralateral side if that area is not affected. And then we will work from the axilla down to the inguinals, redirecting the fluids. We combine deep breathing because the cisterna chyli is in the abdominal area. And by doing deep breathing, we actually are helping with the flow of lymph. I spend a lot of time helping my patients with breathing. We then do compression garments and bandaging. We bandage the limb, and the patient stays bandaged until the next day when they come back. We remove the bandage, we wash the arm, and continue the treatment. And this will be done for 2 to 3 weeks. Very important to have meticulous skin care because there is a risk of infection on a lymphodematous limb. I include an anti-inflammatory diet to reduce inflammation. I co-authored a book on nutrition for lymphedema and for lipedema. So that is phase 1. It's meticulous skin care, manual massage, and the maintenance, which we're going to talk about. What do I do? We do manual lymph drainage, which detoxifies and cleanses the connective tissue of working in a pulsating manner. If there is fibrosis, we go deeper, but it supports the actions of the immune system and it reduces pain by blocking nociceptors. We work on the mechanoreceptors and then we block nociceptors. It relaxes the sympathetic nervous system, so we relieve stress, which is very important for these patients, and we're decreasing interstitial edema and increasing the transport capacity of the lymph collectors. And then when needed, we will shift the edematous fluids to the other side, to another quadrant. And here is the CDT therapy that's done in the clinic, which is daily treatments, manual lymph drainage, compression bandaging, exercises, skin care, patient education, and starting to work with them to teach them to develop the home program, which is phase 2, self-care. We would maintain the reduction at home. Ongoing therapy, we would have them come in still to the clinic maybe once a week or once every 2 weeks, and then once every 3 weeks, wearing compression garments every day and then very often at night, or bandaging, self and manual lymph drainage, which we teach the patients. Often we will prescribe a pneumatic compression device and then still continue with exercise and with skin care. So the goal of treatment is to reduce the swelling and minimize the risk of infection, reduce the inflammation, and enhance lymphatic immune system. There was a study done with complex decongestive therapy along with compression pumping that reduced the difference in the upper limb circumference and the difference in the volume between the affected and unaffected limb. So this study was done with the complex decongestive therapy and the use of compression pumps. There are many compression pumps on the market. I have several that I prefer over others. Very, very important to keep this hygiene as this limb is at risk for infection. We have to keep it very clean and use a pH balanced lotion and soap. In the lymphedema of the leg, we really have to make sure skin folds are clean because they're prone to infection, fungal infections, but that doesn't usually happen on the hand. Use a non-perfumed lotion, which is a low pH, at bedtime, or cocoa butter. The patients are faced with a multitude of challenges after surgery, especially after the onset of lymphedema. And they, as I said, they are at risk for infections, and they're also at risk for dry, cracked skin. And these infections can become systemic and travel to the heart, so it is a danger to the patient's life. So education is extremely important. And I cannot stress how important emotional support is to the patients, because they just are very, very overwhelmed by all of everything that's going on. I'm just briefly going to talk about the microsurgeries for lymphedema, which are very, very exciting. In my clinic, we're working with several doctors who are performing these microsurgeries with the lymph venous anastomosis to divert lymphatic vessels into veins to redirect from an affected area so it can avoid the area that is congested. And then the vascularized lymph node transfer, harvesting a lymph node from a donor site, such as the omentum or the inguinals, to the recipient site. Doctors place the recipient site in different areas. Some go proximal in the arm and others go more distal. And then there is a physician who's not doing the vascularized lymph node transfer. He now is doing vascularized lymph vessel transfer. So that could be a whole lecture on its own. And then they do suction-assisted protein lipectomy. And I think I'm out of time now. So I just wanted to end on a happy note. Forest bathing, which is done in Japan, walking in the forest is very, very healing to your body, your mind, and your spirit. And these aromatic substances have been linked with lower inflammation and brain protective benefits and helping with depression. So anytime you can get into the forest and go and hug a tree, it would be really helpful. I do encourage my patients to go into nature as soon as possible after their surgery. And so I thank you very much. And if there are any questions, I'd be happy to answer. And we're looking forward to new advances in the lymphedema world, because over the last 30 years since I've been practicing, we have really come a long, long way. Thank you so much.
Thank you so much, Dr. Linda. That was a beautiful talk on lymphedema. I would like to invite anybody who's got a question for Dr. Linda regarding her talk. Just show with your hand on the chat, or you can unmute and just go ahead and ask. Okay, we don't have any questions. Thank you so much, Dr. Linda, for your beautiful talk. And I'm going to ask the next speaker to get himself ready to give us a talk on breast reconstruction. And his name is Dr. Thomas Alves Oliveira. Welcome, Dr. Thomas, and the floor is yours.
Good afternoon. How are you? Hope you all fine. I'm going to share my presentation. So let's see. Okay. Can you see it?
Yes, you can. You can just end the show, the slideshow, so we can see the full.
Okay, that's it?
Yep.
Okay, so my name is Tomás Oliveira. I'm a plastic surgeon from the Hospital Santa Maria in Lisbon, Portugal. And as maybe it's a pleasure to be in front of you, and also want to invite you and to discover Lisbon. And it's nowadays it's a very important and to invoke. So, but particularly I work in this Hospital Santa Maria, and it has many vertents and places, and we can do so many things at this hospital. But particularly what I'm going to talk with you today is a particular technique that I would like to show you and for you to know the results. First of all, I would like to say there is no disclosures about this team. And what I'm going to talk is firstly to talk about the goal explain the introduction, the clinical case that we are going to follow, and then finish with a discussion and the conclusion. Okay, so the goal is to describe this technique of a reduction mammoplasty. And okay, this technique, it's a reduction mammoplasty, is a common procedure, and it's used by plastic surgeons to improve quality of life in patients with symptomatic macroplasty or to restore symmetric in patients with congenital discrepancies, or, of course, in the purpose of this team, of after unilateral reconstruction. Although this is a common procedure, adherence to fundamental plastic surgery principles is required to remove excess skin and breast parenchyma and to reposition the nipple while keeping the perfusion of the tissues. So let's continue. Okay. These considerations have resulted in the development and description of numerous techniques for performing reduction mammoplasty. And we can use different skin patterns, reductions, or pedicles designs, okay? The most commonly used technique is the inferior pedicle with a wide incision pattern preferred at the 70% of surgeons, okay? The inferior wise approach offers the safe incision of large tissues, bones, with predictably and reproductively. However, some surgeons have criticized this approach for perceiving shortcomings, and there is many other issues that there is arguing. So there is another option that I'm going to show you. Okay, so what I'm going to present you is a woman with 40 years old with a macroplasty, okay? And she has, as you can see, a big boobs that we are going to, how can we do it with different ways of treating, okay? So what I'm going to show you, the technique that we use is the central mount. Okay, it was introduced by Balch in 1981, and it has been described with so many advantages. First of all, it relies on a highly vascular glandular pedicle directly from the chest wall and can be safely used in re-reduction regardless of the pedicle design using the prior reduction. In addition, the central mount techniques allows the surgeon to precise, predict, and modify the base with the breast mount by shaping underlying corn, pedicle, and draping the skin over the final desired shape. And so, by doing this, by centering the pedicle under the nipple and the point of maximal projection, anesthetizing an anatomical breast contour can be constructed. So, the preservation of the directly underlying tissue also may limit the likelihood of damage to the sensory cutaneous nerves destined for the nipple RL complex. Okay, this is how can we do it. You can see from the beginning that there is a pattern incision, and then the skin flaps are elevated, and then the circumferential breast tissue is removed, okay? And then we can do in two kind of stitches that they are going to do a mastopexy. I mean, they are going to push up the tissue, okay? And then we can finish closing with this, okay? And this is the final result. And as you can see, the photo that I've shown me before, 6 weeks after and 1 year after, okay? And in this case particularly, we have removed 800 more or less from the right and more or less the same at the left side, okay? Okay, this is from the other side, okay? Lateral view. And you can see there is a progression, and its edema reduces a lot during the time, and it's important to have it at mind. Maybe when we recommend a surgery, we have to be conscious that the result won't appear in the 1 week, 1 month. Okay, we have to keep it, okay, and wait, and it's important to tell the patients to know it. About discussion, the central breast mount reduction has, as you can see, a good advantage of being supplied everywhere, and the base of the mount is never violated. Some have called this the technique the maximally vascular central breast mount reduction. Because of what? Because it's perforated from the internal mammary, intercostal, thoracoacromial, and perhaps some branches from the lateral-thoracic, they all can contribute to central mountain vascular supply. And it's a great advantage that we have to enforce and we have to say. Okay, so this will enable the central mount technique to be used from all appropriated breast reduction candidates. Okay, and it's important as to have to keep in mind there are no specific contradictions, so it's a good option. But okay, let's focus which are the main and the significant advantages of this technique. There is a wide skin undermining, okay, that will allow redraping of the overlying skin envelope in a much more controlled and tension-free fashion. There is a circumferential resection of the large endothoric breast parenchyma in a dome-shaped fashion. And it will create of an internal parenchymal mastopexy by securing the upper pole of the new breast mount to the upper glandular ridge of the pectoral major fascia. Okay, and it's okay, of course, as you can imagine, a tension-free closure of the skin flaps. So you can see there is a lot of it can be used. Okay, but I would like to conclude saying that the central mount reduction mammoplasty will offer relative safe and effective methods for treating all this kind of patient. I mean, it's even just in the reduction mammoplasty, if it has a after a second time reconstruction or an asymmetry or a macromasty. Okay, there is a lot of advantages of using this because mainly because of the vascular supply, and it's important, as I repeated before, to keep in mind. Okay, but okay, the versatile reduction, the preservation of the nip sensation, these all good points that we have to focus. Okay, and the perfusion, and sometimes also the mastopexy that can also contribute to give a upper mood to the breast. Okay, and I would like to finish, and I'm available to any question that you can have.
Thank you, Dr. Thomas. I seem to have, oh, okay, there we go. Thank you so much for that beautiful talk. And I want to ask anybody if anyone has a question for Dr. Thomas for his talk. Do we have any questions? Please feel free to ask any questions so we can engage. Alternatively, you can, if you don't mind, you can leave your email. Maybe people can ask questions later, but thank you so much for that. Thank you. Okay, next up, we are going to be moving on, and we're going back to Portugal, Dr. Andrew Laceda, and he's going to be giving us his next talk. I don't know if he's ready. I don't see him.
Oh, he called me. He had a problem. I guess he's not able to present. He didn't contact with you?
So to say that again, he won't be able to present.
I guess so, because he has just called me and he think he could manage, but I'm not sure. He said he will contact you, but
Okay,
I don't know.
no problem. No problem. Next up, we're going to be moving to Dr. Saika. I don't know if Dr. Saika is available. He's going to give us a talk on benign breast diseases, 1 year experience at a community hospital. Dr. Saika, do we have you ready? I can see Dr. Saika, I think you're muted. If you could just indicate, or do you need a few minutes? Dr. Thomas, apparently you're next up. Are you giving another talk?
Okay, I have another one, yeah, also.
Okay, all right. So I think you can just, yeah, you can share.
Give me just 1 second, okay. Okay, now we are changing a bit of the team, but okay, we focus in that team. Okay, let's talk about the breast reconstruction, but now we do the pedicle perforated flap. Okay, and I'm going to show you, as the same as I showed you before, a clinical case that I can show you, and with a quite good enough result that it's also an option for us to use it. So about what I'm going to say. I dispense now my presentation, my invitation to Lisbon. Okay, as you may also see, I'm a plastic surgeon in the Hospital Santa Maria in Lisbon, Portugal, and now I'm going to talk about the introduction. Okay, explaining you the flap definition. I'll say, I mean, what is this kind particularly of flap that I'm going to say, their own indications, presenting it's the case, and finally, the same as before, with a discussion and a conclusion. Okay, so this thoracodorsal artery perforated flap, or TAP flap, is a faciocutaneous flap based on a musculocutaneous perforated or perforated from the thoracodorsal vessel axis and or its vertical branch derivate. I mean, okay, if we have a breast defect, we can group it in some parts, and with in the all breast quadrant, excluding the medial quadrant, we can use this particularly flap. Okay, it's the one I'm going to talk to you about. Okay, was originally described in 1995 by Angry G, and has a method of diminishing the volume of the conventional latissimus dorsi myocutaneous flap. Okay, and then it changed a bit with the time, and now it's used the way that it's used today in many countries. Okay, this is not it is a quite common flap used. Okay, this indication we can use it in three different ways. Okay, as an island, as a free flap, and as a pedicular flap. Okay, as an island, it's used for resurfacing of axillary shoulder or ipsilateral breast or anterior thorax lesions, providing excellent tissue match for head and neck and extremity reconstruction. So you can see from now that okay, it offers quite options to cover. Okay, as a free flap, it's okay, even more flexible, and is indicated whenever a large area of the skin and subcutaneous tissue is necessary, and a long and large vascular pedicle is preferred. For example, for large ankle and lower leg lesions or cranial lesions when the anastomosis are performed to the neck vessels. Okay, and also as a pedicle flap in the more closer one, and it can be used for lateral neck, for pharyngeal, tubing, breast, axilla, and arm. Okay, so you can understand that we can use because it has a pedicle and in the closer area. Okay, so I'm not to explain you too much about this because it's not a plastic surgery congress, but okay, there are three types of this flap, and it depends on the amount of muscle that is associated with the perforators. Okay, but I don't think it matters to explain this here. Okay, and what I'm going to talk about now is the clinical presentation. There is a female with 46 years old, and the status post-cancer with the breast submitted to a superior supraexternal quadrantectomy of the right breast with an axillary scar band. Okay, so the main problem was this scar. Okay, and it's here. How can we solve this problem? Okay, because okay, in Portugal it works like this: the general surgery take the ones who is particularly dedicated to breast cancer. They took the first time the tumor, okay, and the second time we can reconstruct. So let's see what we can do. We made at the beginning an excision of the scar band and use a right at the ipsilateral side the reconstruction with TDAP flap. Okay, and on the other side we did a control mastopexy of symmetrization. Okay, the pedicle that we use is not important here, but okay, we use a superior one with a vertical scar. This is the marks that we use to construct the TDAP flap. Okay, here the TDAP flap, okay, that we are going to use, and here is the scar that we want to make the excision. So this is intraoperative photo. Okay, as you can see, the TDAP flap that it's now almost ready. Okay, and it's then moved. Okay, with the vessels, as you can see, and here you can see the scar that we had taken off. And as you can see, okay, this is the 6 month post surgery that we had as a result. It's not a perfect one. Okay, of course I can deal, but you can see that there is not the hole that has before. Okay, so it was a better solution, but not a perfect one. But I can see, but as what I want to say is that okay, it can give some volume. Okay, at this time. Okay. And if we can do it with leather, better at another surgical temp or surgical time after, we can like make a bit of graft of fat graft or something that will even turn it better. Okay. So to discuss it, okay, as you can understand, this kind of flap has clear advantages because it has a comparable thickness to that of the extremities, allow two-team approach, a lower incidence of the pedicle affection by atherosclerotic changes, okay, and the length of the pedicle it's quite big, okay, and it's a good diameter, so it's good to keep the perfusion. It's a low donor site morbidity because you can see the muscle is big enough. It has a stable coverage and it has a acceptable excision appearance. Okay, I told you acceptable. Primary closure of donor side with flat with up 10 centimeters, and donor scar can be hidden by underwear, possibly of a sensor flap, and the possible chimeric of combined flap, including muscle bone. Okay, it's a clear invention, but I don't think it's the focus here to discuss this. And it has also the versatility of the skin pedal orientation, and also defecting, leaving 2 centimeters subcutaneous tissue to cover shallow defects. Okay, and the bulk of the flap and the donor side morbidities change the direction towards harvesting a perforated flap and preserve the muscle function. In addition, the denervated muscle included in the flap undergoes an unpredictable degree of atrophy, making the volume or reconstruction more doubtful. Okay, we have also to say that in everything we have advantages and disadvantages. So this is a clear and an advantage. And reported some disadvantages of the TDAP flap has increased the operative time by patient positioning and perforated dissection, possible donor site scar, wedding and hypertrophy, skin paddle, still bulky in obvious patient, and the need for meticulous preparative planning and perforated method. And as a conclusion, the versatility of the TDAP has several advantages that make it a workhorse flap for most reconstructions requiring soft tissue cover. Its use in chimeric with the underlying latissimus dorsi muscle provides reconstruction for coverage and volume replacement. So as you can see, it has a good offer, a quite good offer, because it has, with that we can reconstruct the very defects or many kinds of defects that exists. Okay, and now I finished my presentation. I'm ready for any questions that you can have, any doubts. Okay, feel free, please.
I wanted to find out with regards to these breast reconstructions, do you get to see these breast implant related lymphomas which have been emerging? Do you know if that is a common occurrence in your hospital? I don't know if you're aware of those
Can you repeat
lymphomas
your
that
question? I didn't understand.
I'm saying with the breast implants,
Yeah.
are you seeing a lot of the lymphomas that arise as a result of those?
No, we don't have many reported cases with lymphoma associated with breast implants. Okay, that's okay. There is some studies that effectively report it, but effectively in practice, there it's not so common. Okay, and the breast implants, even with the time passing, they are getting even more and more safer because the properties that they have, they are changing. Okay, and also the patients that they have breast implants, they also have more caution. I mean, they keep it safe. They do regularly exams, and it permits to be safe. Okay, so actually we don't have many cases. I don't know. What I'm thinking, I don't know anyone. So I think it's quite safe. But as I told you, the materials, the early observation with this patient, it's quite important. So, but it's lymphoma associated with it. We don't have any notified. Okay.
Okay. Does anybody else have a question for Dr. Thomas before he steps down? Okay, thank you so much, Dr. Thomas, for doing your talks in a row. Sorry you had to do that consecutively without taking a break, but thanks for accommodating us.
It was a pleasure. Thank you for the opportunity as well. Okay.
Thank you. Next up, we have Dr. Saika from India, if I'm not mistaken, and she'll be doing the benign breast diseases. Over to you, Dr. Saika, whenever you're ready.
Hello, good afternoon, everybody. Am I audible?
Yes, you are.
Okay. Can you see my screen?
Not yet. They say double click to enter the full screen mode. Can you try again sharing? Are you sharing the screen?
I am sharing the screen. Just a second, please. No, it doesn't seem to be working. Just a second, please.
What are you seeing on your end? Maybe they.
Yeah, I think my screen is hanged. Just a second. I think there's a glitch.
Dr. Saika, there's a request that if you could send the slides to the committee so that they can share them for you. They say that stop sharing, they will share on your behalf. And your screen has frozen now from my end. I'm not sure if everybody is seeing that, or is it just on my end? You can see the slides now. But we seem to have lost Dr. Saika. Dr. Saika, are you still there? I'm not sure if we want to move on or do you want to wait for Dr. Saika? I seem to have completely lost her. Is Dr. Brian perhaps ready? Because we seem to be on a frozen status right now. Apologies. I'm trying to see if we can get the next speaker ready. Would Dr. Brian be in the room perhaps? So we could give him a platform because we've lost Dr. Saika. Maybe we can have her later. Apparently, Dr. Saika is back. Dr. Saika, if you could just unmute wherever you are so we can have you back.
Am I audible now?
Yes, you are.
Okay. Is the presentation visible now?
Yes, they've got it up for you. Dr. Saika, you can go ahead and with your talk. I think they'll be sharing the slides for you.
Am I audible?
Yes, we can hear you. Yes, you are. You are. Please go ahead.
Okay. So, hello, sorry for the glitch. I'm Dr. Saika Amreen. I'm from Kashmir, India, and I'm going to be presenting about benign breast diseases, our experience at a community hospital. So this is going to be dealing with the concept of breast ultrasound. So ultrasound is a very dynamic and cost-effective, efficient tool to evaluate the breast. And the basic thing about ultrasound, which makes it a little different from mammography, is that it can distinguish among many different types of normal breast tissue. So if you can see on this, on the ultrasound, so the skin will appear as a very bright layer, while as the lactiferous ducts, they are not usually seen, but they are only seen when they are dilated. These bright thin lines are the Cooper's ligaments, which we can see on ultrasound, tethering the tissue to the skin. And as the patient's age increases, these lines get prominent and are more better visualized. And the ratio of the parenchyma to fat will vary with the patient's age as well as the hormonal status. Now, the primary aim of breast ultrasound is to differentiate between cystic and solid lesions. And we can evaluate palpable masses which are not visible at mammography. In young and pregnant patients where mammography is contraindicated, breast ultrasound is a better option. It's the primary diagnostic modality for evaluation of nipple discharge and can help us to describe the lymph node status as well. Ultrasound can help us to prevent any negative biopsies and also to prevent any unnecessary short interval follow-up. We can guide into.
I'm sorry
Yes.
for interrupting in between. Could you please guide us by saying us next, because we are playing your slides.
You're playing my slides?
Yes.
Okay. So which slide are you on right now?
Number 2.
Number.
Yeah, it's number 3.
Just a second, please. Number 3. Okay. So please go to the number 4.
Yeah, thank you.
So the primary aim of breast ultrasound is to help us differentiate between these cystic and solid lesions. And the basic rule of breast ultrasound is to prevent any negative biopsies, any unnecessary short-term interval follow-up, and to guide interventional procedures. Ultrasound can help us improve our clinical skills as well as our mammographic skills. Next slide, please. So why is ultrasound important? Ultrasound, the majority of women who come to our clinic with a palpable lesion or for a breast consultation actually have a benign pathology. So ultrasound can reduce the number of these unnecessary biopsies and avoid any diagnostic delays. So once we are using ultrasound at a community center, we can filter out the people who actually don't need any further investigation and can be sent home with a benign diagnosis. Next slide, please. The technique that we use for ultrasound uses a radial and an anti-radial pattern. So all positive findings, whatever positive finding we have, it has to be evaluated in both these directions, the radial as well as the anti-radial plane. Next. For reporting of the ultrasound lesion, we use the ultrasound BI-RADS lexicon. So in this, we have to comment on the breast composition, whether the breast is homogeneous, heterogeneous, the predominant component is fat or fibroglandular parenchyma. We can comment about the mass, the shape, margin, orientation, the ecotexture of the mass and its posterior features. Whatever, if the mass has any calcifications, then if there are any associated features, any architectural distortion, duct changes, skin thickening, edema, some cases may have a special diagnosis like a clustered cyst, a foreign body, an AVM. So the utility of the ultrasound BI-RADS is that once we are using a uniform terminology, our reporting will be uniform. This will help us in easier follow-up, easier comparison, and a characterized mechanism of management. Next. Once we have assessed a lesion and used the BI-RADS lexicon, we can assess the lesion according to the final categories. And there are 6 categories, and the 0 category means that we have not reached any conclusion. We need additional imaging, we need prior examinations, or we can recall the patient. So ultimately, it is an incomplete examination. BI-RADS 1 means it was a normal examination without any significant finding. BI-RADS 2 means it was benign. So after BI-RADS 2, BI-RADS 3 will again follow up because it is a suspicious lesion. 4, 5, and 6 are suspicious for malignancy. In order to diagnose a BI-RADS 2, next slide, we have to ascertain certain characteristics. If there are simple cysts, they can be diagnosed as BI-RADS 2. In order to diagnose a solid lesion for as BI-RADS 2, we have to understand and we have to recognize certain identifying characters. These identifying characters include an elliptical shape or a horizontal orientation, a well-defined curvilinear or a slightly lobulated margin, and a presence of a complete thin echogenic capsule, or an ecotexture which is completely hyperechoic. Next. Whenever any of these characters is not followed, we will upgrade the lesion to a BIRATS 3 category. The decision has to be made on the feature which is most malignant. Most malignant meaning even if one characteristic of the lesion is suspicious, it is that characteristic which will be the defining feature, because even if that characteristic is a minor according to the objectivity of the person who is doing the ultrasound, it may be the most determinant feature. Next. The role of power Doppler is not really received in literature. Power Doppler was initially thought to be very important because we thought that once a lesion would have more vascularity, there will be a more possibility that this lesion would be malignant. However, it turned out that even benign lesions can have a good vascularity, inflammatory lesions can have a good vascularity. So the use of Doppler to differentiate between benign and malignant lesions is not really well established, and it's still in vogue. However, we do continue to use Doppler in daily practice in order to define certain characters of the lesion. Sometimes if a lesion is very vascular, it will draw more attention to it. Next. So the ultrasound image is a topographic representation of the breast itself. And we are going to describe in this presentation whatever benign breast lesions we encountered in the community hospital over a period of 1 month. Next. So most of the breast lesions which we identified, the most common breast lesion which we identified was a fibroadenoma, followed by the breast abscess. Next. Representative cases. Next. So the first is the fibroadenoma. Fibroadenomas, these are benign solid tumors, and these develop from the terminal ductolobular lumen due to uncoordinated proliferation of the epithelial and the stromal component. And these are one of the most common lesions that we encounter in daily practice. The tissues of the breast of the fibroadenoma are compressed, and they form what is known as a pseudocapsule surrounding it. And this is a characteristic feature of a fibroadenoma. Next. The most common incidence of fibroadenoma is in the 3rd and the 4th decade of life.
Recording in progress.
During pregnancy and breastfeeding, these lesions may become more irregular due to episodes of infarction and more difficult to distinguish from carcinomas. Fibroadenomas can have varying sizes as well. Next. So here are 2 images. The topmost image shows a well-defined hypoechoic lesion, which is wider than it is tall. This lesion has a echogenic capsule which is surrounding it. The Doppler image shows that the lesion has a peripheral vascularity. This is a typical fibroadenoma. If we see the posterior part of the lesion, the posterior half shows a brighter echogenicity as compared to the both sides of the nodule. This is called as posterior acoustic enhancement, and it is again typical of fibroadenoma. Next. If the nodule presents a microlobulated appearance, then it gets upgraded. So any lobularity in the nodule should be taken with precaution. Any evidence of the fibroadenoma being complex should also be taken with suspicion. These will include a microcalcification, which will be associated with ductal hyperplasia, a heterogeneous ecotexture, or presence of small hyperechoic areas. Presence of any of these factors will upgrade the lesion from a BIRATS 2 to a BIRATS 3 lesion. Next. The next most common benign lesion which we encounter in our population is the abscess. These are infections from the subareolar or pre-existing galactoseals or from puerperal mastitis, which subsequently get infected by bacteria. So these are ill-defined heterogeneous lesions with a lot of areas of liquefaction which can be drained out. And sometimes they show increased vascularity on power Doppler as well. Next. Most common organism in the breast abscess is the staphylococcus. So if a breast abscess is not treated properly, it will develop a necrotic cavity, and then the pus will float in that cavity. Sometimes it can even rupture to form a sinus. If it originates from a pre-existing galactocele, the abscess may be multiloculated. Sometimes in perimenopausal women, we have subareolar abscesses, which are often multiloculated. Next. So what is the role of ultrasound in a breast abscess? We need to diagnose an abscess as early as possible. We can obtain fluid from the abscess for culture and sensitivity, and we can drain the lesion percutaneously. This drainage can be a repeated guided aspiration or a USG guided catheter drainage. Next. This is an example of a small abscess at a very typical location, which is called as the Montgomery gland abscess. So this is seen just adjacent to the nipple. It is a very typical location, and this can be very painful for the patient. As you can see above the skin, there is a dark layer. This dark layer is actually the acoustic window that we create by using excessive amount of gel, since this lesion is so superficial and difficult to visualize. Next. Periductal mastitis affects two groups of women. One is women in their late teens and early 20s. The second is women in their perimenopausal age. Now, why the women in late teens? In them, periductal mastitis is usually associated with congenital nipple inversion, while as in women in perimenopausal years, the periductal mastitis is usually hormonal. It is one of the most common causes of non-cyclical focal breast pain. Next. So once we evaluate the focal area of pain on ultrasound, periductal mastitis is a very typical appearance. It shows us thickened isoechoic ducts, and the duct walls are thickened, the duct walls are brighter and hyperechoic on color Doppler. Usually this change is focal and it is concordant with the area that the patient is feeling pain in. Next. However, we must remember that the appearance of periductal mastitis will vary according to the stage of the disease. If it is an early disease, there will be a lot of fluid in the ducts, which will make them anechoic. However, if it is a prolonged, long-standing condition, these ducts will now have secretions which are very thick, and then the ecotexture will become hypoechoic. Again, it will become difficult to differentiate because now they will be isoechoic. So the sonographic appearance of a focal acute non-purpular mastitis is similar to that of a purpular mastitis, except for being more localized. Next. Now, it is prudent that all of these patients receive antibiotics, even though the pathology is chemically induced. The reason is that there is almost always an associated secondary bacterial infection. And on imaging, we cannot differentiate whether the mastitis we are seeing is chemical or bacterial. Next. Sebaceous cysts are very commonly encountered, and usually they don't offer us any difficulty in diagnosis, but sometimes it can happen. Now, the appearance of a sebaceous cyst depends on the time of obstruction. If it is a very acute obstruction, then the cyst will have a lot of fluid in it and it will be anechoic. That means it will be blacker. If it is a more chronic obstruction, the cyst will have thicker, more lipidaceous, keratinaceous material within it, and now it will appear brighter or hyperechoic. Next. The location of this sebaceous cyst is also very typical. So it can be completely within the skin. It can be partially within the skin when the skin appears like a claw surrounding it, and it can be deep within the skin. In this presentation, a gland neck or the hair follicle will be shown coursing through the skin. All of these can be appearances of a sebaceous cyst. Next. If we have a non-inflamed sebaceous cyst, it will have no blood flow. The walls will be very thin. It won't be tender. But once the sebaceous cyst is inflamed, it will become more hypoechoic. The walls will become thicker and there will be increased blood flow. So it will be hyperemic. The most common differential of a sebaceous cyst is an epidermal inclusion cyst. And we have to remember that epidermal inclusion cysts are brighter, coarser, and more heterogeneous. Now, in this image, if you see the sebaceous cyst, there is an artifact which is coming. Like multiple lines are coming. So the reason is that the cyst is so superficial that inadvertently air enters between the skin and the probe. So there is not a complete contact. Next. Intramammary lymph nodes. These are the most common location is the upper outer peripheral quadrant towards the axillary tail. So most commonly, how do we identify them? These are oval, lobulated, isoechoic, and they have a nudge, which is hyperechoic, which is actually the hilum, and we can also see a central hilar artery. Next. Fat necrosis is one of the difficult diagnoses on ultrasound. The reason being that the appearance of fat necrosis will vary according to the stage of development. It will also depend on how the amount of hemorrhage that had taken place, what is the stage of cyst formation and the fibrosis. There can be many causes of fat necrosis. Next. So in the earliest phases, we only see edema. Now, how to differentiate this edema? If this fat necrosis is only in a small area, so we can easily compare it to the adjacent normal breast parenchyma, and fat necrosis will appear hyperechoic. However, in some cases, when there are extensive traumatic events or diabetic mastopathy, the edematous area is so extensive, so it becomes very difficult to differentiate which is normal and which is abnormal. In those cases, comparison with the contralateral breast may aid, but sometimes even that is difficult. This hyperechoic edema of fat necrosis is not distinguishable from any other edema. So the history of the patient is very important in making the diagnosis. Next, isolated fat necrosis progresses beyond the edema stage, forming ill-defined complex cystic lesions. So if you can see in these images, there is an ill-defined irregular area with tiny cysts, and this area was at occupying a quadrant of 3 to 6 o'clock, and the patient had a history of trauma. And this is the typical appearance of fat necrosis once it comes to ultrasound 1 to 2 weeks after the trauma itself. If a traumatic event or if led to formation of a hematoma, so the sonographical appearance will correlate with that of a hematoma. Next, hemangiomas. These are benign vascular tumors. Most of them are subcutaneous. They may be polynodular, oval, or lobulated. The echogenicity of a hemangioma depends on the size of the vessels. So capillary vessels, which are very small, will have a bright appearance, and cavernous vessels, which are very large, will have a mixed appearance. Next. Intraductal papillomas. These are very common lesions encountered in daily practice. So what we see is that the papilloma, it has a bright appearance and it is within the duct, which is filled with fluid. And we also may be able to see a fibrovascular stalk on Doppler, which appears as a bright artery. And there is a well-circumscribed lesion. So any well-circumscribed lesion should be suspected for an intraductal papilloma. Next. Now, how does a papilloma evolve? Once the papilloma is very small, it starts by secretion and causes dilatation of the duct. Once it starts growing, part of the papilloma undergoes infarction and necrosis. And that is one of the reasons of the serous discharge becoming bloody. So a common presentation is a patient coming with a bloody discharge from one duct. Once the papilloma grows more, it causes obstruction, and the continued secretion forms what is known as a cyst, and the papilloma is present inside the cyst. This is called as an intracystic papilloma. Next. So in early stages, the papilloma may appear hypoechoic and show a vascular signal, and later on there will be expansion, and we may actually see a large cyst within which a solid component is seen. Next. Compression technique is very important for diagnosis of papilloma, because once the papilloma makes a lot of secretions, the duct is filled with debris and secretions and blood clots, and it is difficult to distinguish where the solid component actually is. So if we try to compress all the ducts which are dilated, the duct where there will be a residual circumscribed dilatation will represent a papilloma, and papilloma can be assumed as such. When a papilloma is intracystic, it is not only the intracystic solid component that is important, but we have to see where the papilloma is actually extending outside the duct. So it requires a careful evaluation. Next. The location of the papilloma is very important. Large retroareolar ducts usually have single papillomas. These are seen in perimenopausal age group and are usually benign. Multiple smaller ducts in the periphery usually have multiple lesions. These are seen in younger patients and often associated with juvenile papillomatosis, and they have a high risk of malignant transformation. Next. So in order to distinguish whether it is a high risk or a low risk papilloma, we need to pay attention to these features. So an angular attachment or a duct extension or a fibrovascular stalk and microablulations are high risk findings, while as a lacy hypoechoic texture is a low risk finding. Next. The most common abnormal disease process of the male breast is called as gynecomesia. So gynecomesia actually means a breast like a female. So a larger breast in a male has a suspicion for gynecomesia. Gynecomesia is basically benign proliferation of the subareolar, ductal, and periductal stromal tissues. So it may be pubertal, or it may also occur during andropause. It may also be drug related. Next. The appearance of gynecomesia changes according to the stage. Very early gynecomesia is usually very painful, called as mastodynia, and once the tenderness diminishes, the palpable abnormality usually persists. Patients may also have nipple discharge. Any palpable abnormality has to be differentiated from pseudogynecomastia, which is just the deposition of fat. Next. Now, this is an ultrasound picture, and it actually helps us to identify all three phases of gynecomastia. The first phase is the proliferative phase. So in the proliferative phase, usually it is very difficult to differentiate on ultrasound. Gynecomastia appears hypoechoic. So there are angular margins, the branches are very prominent, the subaerial ducts are very prominent, and they are dark or hypoechoic. In the mixed phase, the ducts are hypoechoic, but the periductal fibrous tissue now is more brighter. And in the quiescent phase, the ducts now don't dominate. It is the hyperechoic tissue which dominates. So in this image, you can see it is in the mixed phase. We can see the marked prominent hypoechoic ducts, and surrounding them, there is the hyperechoic dense periductal fibrosis. Next. Phyllodes tumor. Now, this has been an area of controversy since it was diagnosed, and it may also be called as cystosarcoma. There's a classification which divides phyllodes tumor into benign, borderline, and malignant, but it is still very difficult to differentiate a phyllodes tumor from an atypical fibroadenoma. Next. 2 to 3% of all fibroepithelial lesions are phyllodes tumor, and the difference is that there is an intraductal growth of intralobular stroma. There are a lot of pseudocystic spaces on the phyllodes histologically, and any atypical fibroadenoma should be screened for phyllodes determination histopathologically. Next. So what is the appearance on ultrasound? A large hypoechoic lesion with lobulations, with a capsule, which is actually a pseudocapsule, with posterior acoustic shadowing, looks like a phyllodes tumor. It has a lot of pseudocystic spaces and hyperechoic striations. It is the presence of these striations. Striations are the hyperechoic bright lines which are present in the lesion that are characteristic of a phyllodes tumor. Now, the presence of pseudocystic spaces is seen in benign phyllodes, but as the rate of malignancy increases, these pseudocystic spaces become coarser and the ecotexture becomes more heterogeneous because now it is associated with a lot of necrosis. Next. So in the past, it was not unusual to see that patients presented with phyllodes tumor of more than 10 centimeters, but nowadays we do make diagnosis earlier, and it is the malignant transformation of the phyllodes that is very precarious, and it may lead to hematogenous distant metastasis. So any phyllodes tumor or any tumor with a suspicion of phyllodes needs to undergo surgical excision. Next. Milk fistula, it is an iatrogenic condition. It is develops when there is a potential complication. Whenever there has been a biopsy of a lactating patient, she has to be made aware of this possibility that a milk fistula may develop. So this fistula is between the skin and the lactiferous ducts. So the duct and the skin communicate, and there is a discharge from the skin, which is lactiferous. Usually patients have to go undergo conservative management, but sometimes they may need surgical excision of the fistula. Next. So on ultrasound, we can visualize the track of the biopsy needle as well as the cutaneous connection. There may be internal debris which may be visible, and the entire tract usually seals on by its own in a few months, but if it doesn't, then a surgical excision is required. Next. So my take-home points would be that most of the lesions which are benign, which are characterized as BIRATS 2, are diagnosed due to their characteristic appearance or their characteristic location or a particular history. Some lesions may be very difficult to diagnose due to different stages of evolution, like an abscess or an intraductal papilloma. Some lesions are difficult to differentiate from malignant lesions, like phyllodes. In determining benignity of a lesion, these four characteristics have to be taken in mind. The lesion which is elliptical and horizontally oriented, a lesion which is well-defined, curvilinear, a few lobulations are permitted. If it has a thin echogenic capsule, and if it is completely hyperechoic, any deviation from these characters should upgrade the lesion to at least a BIRATS 3. And decision should always be made on the most malignant feature. Next. These are my references. All of these are cases which have been taken from our hospital after informed consent. Thank you.
Sorry, I forgot to unmute. Thank you so much, Dr. Saika, for
Yes,
a wonderful
thank you.
presentation. Yeah, I must say the phyllodes, they also give us gray hair as well as the abscesses. I don't know if you mentioned this, but when you in your setting, what is the commonest cause of the breast abscesses?
Yeah, actually, we have a variety of breast abscesses ranging from a lactational mastitis to perimenopausal abscesses. And one thing that we have here, which is very common, which is not much seen in Western countries, is the granulomatous mastitis. But that always remains a BI-RADS 4 because the lesion is so heterogeneous, it is so difficult to differentiate whether it is actually benign. We ultimately end up doing a biopsy. We have granulomatous mastitis tubercular also, and we see non-tubercular also. So that is one of the very common lesions which we see. And whenever we have an abscess, we routinely send an abscess for not only for culture, but for a acid-fast bacillus staining as well to rule out tuberculosis because it is very common in the community.
Yeah, no, we also see a lot of TB breast, which is an extrapulmonary manifestation of AIDS in our setting, but it's quite difficult to culture the acid-fast bacilli. So it's usually a problem. But thank you so much for your talk. And I want to give an opportunity to anyone who has a question for Dr. Saika, please. There doesn't seem to be any questions for you, but thank you so much for your talk, and sorry about the glitches. Next up, we have Dr. Michael. Unfortunately, we're not able to have Dr. Brian because he has had to rush to do a intraoperative assessment of some sort. So now we have Dr. Michael, and he'll be taking us through the breast cancer and perioperative window, and he is from the USA. Welcome, Dr. Michael. And if you could please share your screen as soon as you are ready and start with your talk.
Can you separate, can you run it from your end? I sent off the slides this morning.
I'm sure that can be arranged. If you could assist the technical team, if they could share Dr. Michael's talk.
Yes, thanks. Thanks. Can you open up the that main picture? Is this all right the way it is? Okay. This project was supported by funds from NIH and the Komen Foundation. No other conflicts to report. Next slide, please. Just as some background, some years ago in 1962, Thomas Kuhn discussed the structure of scientific revolutions. And he said there are 4 different phases of science. And when it starts off, initial science is pre-paradigmic. This is a situation where there's very little understanding and agreement among the researchers as to what is the mechanism, what are we looking at, how do you do the experiments. After a while, this gets to the point where there's some cooperation and agreement among the various researchers. And this is called normal science by Kuhn. And this could go on for a very long time. Textbooks are written, and this seems to be in a stable situation. Once in a while, you can get some anomaly. You can come up with some new data that are not explainable by this normal science. And this is called a crisis by Thomas Kuhn. This can be resolved in 2 ways. It can go back to normal science. Maybe someone just a little smarter than the other guys or gals could come up with an explanation for this new data, for these new data, and it can go back to normal science. But if after a while no one can come up with an explanation, then you have to consider that this is a paradigm shift or a scientific revolution. Next slide, please. This work was started a long time ago, and one of our major reports was a book published by Springer Nature, and it was promoted, advertised on the front page of the New York Times, and this got my attention because this doesn't happen every day. This is right after the last presidential election in the U.S. in November. Next slide, please. This is the foreword to that book. Was written by Robert Weinberg, a very well-known and respected cancer biologist at MIT, at Harvard, at Cambridge. And I'm compressing two things here. First, Dr. Weinberg said, if this can be definitively demonstrated, leads to the notion likely to be accepted only reluctantly by many in the clinical oncology community. And I can tell you that's happening. A lot of people just don't like the idea that there's something new out there. It's pretty far away from the way science has been taught in this subject. And primary tumor resection does not provide an undiluted benefit to the patient in terms of long-term survival. And Weinberg concludes by saying this is likely to profoundly influence surgical oncology in the future and post-surgical treatment protocols. Next slide. This is a project that's been going on for a very long time. I can tell you when it started. 1993, I was attending a breast cancer conference in Europe, one city. I don't even recall what city it was. And out in the lobby, I saw a poster presented by Romano Demichelli from Milan. He was showing databases from their community, from Milan, and talked about, they found there was a bimodal relapse pattern. There was an early wave of relapses in the first 3 years, and then there seems to be a minimum, and then it started up again. This is unusual. This is not the way cancer has been thought of about breast cancer. I will describe this in more detail later on, but there was a sharp peak at about 1.5 years, a minimum at about 4 years, and then it started up again with that broad peak at 5, 6 years, with a long tail extending to 15 and more years. And this general pattern has now been identified in over 21 databases from US, Europe, and Asia. There are more than 21, but I stopped counting at that point. Next slide. Okay, these are data from Romano Demichelli. What you see here is relapse data in the hazard format. Hazard means someone enters a certain window relapse-free, and they undergo a relapse. In this case, the window is 3 months wide. And you can see there's a surge in these relapse hazards at about 18 months, a pretty sharp surge, and it goes down to at about 48 months, 4 years. And that seems to start up again with 60, 70 months, going on to 10 and more years. This little blimp at about 100 months. We're not sure what that is. It could be noise or it could be important. Next slide. Oh, by the way, that was for postmenopausal patients. This is for the premenopausal patients. Same information, but the patients are in the premenopausal status. Everything is the same except that first peak, that first 18-month peak, now shows to have some structure in it. There's a sharp peak at about 10 months, and then another peak that's also sharp at about 30 months. Other than that, it's very similar. You got that peak at 50, 60 months, and then that long tail going on to over 10 years. Next slide, please. These are the Milan data presented in the more conventional disease-free survival format. This was presented by Bonadonna Valagusa in the New England Journal, 1995. Bonadonna was the clinician. He died some years ago. He is very well known as a person who first used multiple drugs to treat breast cancer and adjuvant chemotherapy. And Panuccia Valagusa was a database manager since this project started. And I have a lot of experience with different databases, and I really trust these data. And a good part of that is due to the presence of Panuccia Valagusa. In Italy, women typically stay in the same communities, cities, and towns for decades, so that there are few patients lost to follow-up. And the other thing is having one person, one competent person, Panuccia Valagusa, be the database manager. I've seen so many databases where they switch data managers and all of a sudden things are different and you don't get that continuity. The other thing is that in Italy, women are considered to have be more compliant with physician directives. So for those reasons, I highly recommend that the Bonadonna Valagusa database is a respectable database. What you see here is that the early relapses, that first 5 years, you get, actually most of it happens in the first 3 years. And then it reaches sort of a plateau at about 5 years, and then it starts up again. This is not what you would expect if there was one mechanism going on. There clearly are at least two mechanisms, maybe more. Next slide, please. This was a figure first published by Bernie Fisher in 1984. Fisher is well known as the person who first came up with the idea of conservative therapy, conservative surgery, lumpectomy is what he termed it. And these are the relapse-free survival data for patients treated with just surgery. This is well before the use of conventional chemotherapy. And these are the relapse rates for the disease-free survival for patients grouped by nodes positive. The curve on the top is for patients with 0 nodes, and then 1 to 3, 4 to 6, 7 to 12, and then on the bottom, we have more than 12. And I want to focus on those two extreme cases, the 0 node population and the more than 12 node population. I was attending a conference and somebody flashed this figure, and I can immediately see this is very similar. Hold on a second, there's some background noise. Where?
I have to use it.
Give me about 10, 15 minutes. Sorry for that. This figure was presented by Fisher. Where was I? Okay, the figure on top is for the 0 node population. This very impressed me as looking much like the Milan data, but this is in a different country. This is also a well-respected database. You can see for the 0 node population, simply removing the primary tumor, 80% of patients are cured. They will not have a relapse. But of the 20% that relapse, about 10% of them relapse in that first 3-year period. And then there's a phase with very few relapses. Then it starts up again with this long, shallow peak going out to 10 years and more. If you go down to the lower curve, the ones with more than 12 nodes positive, the same things happen, but the numbers are vastly different. For example, all the patients relapse if this is before the time of conventional chemotherapy, and having more than 12 nodes is a very poor prognosis. But of the 100% that relapse, about 85% of them relapse in that first 3-year period, the same timing as the 0 node population. And then there's a phase of a number of years with very few relapses, then it starts up again until you get at 96 months, you get to the point where all the patients have relapsed. This is telling us something. Something is going on for 0 node population that 10% of those patients have some early relapse. And if you go down to the more than 12 node population, more than 80, 85% of the patients have that same relapse. The numbers are just different, but something is going on very similarly between those two populations. Next slide, please. Okay, this general pattern was just not explainable with the continuous growth model that has been the guiding biology for early detection and therapy for many years. Something is going on that is not in reasonable agreement with what has been considered to be the explanation for how cancer grows. Next slide, please. Okay, Romano Demicheli and I decided to collaborate. I have a background in experimental physics. I made a career change in the early 1980s, and I became pretty competent in the use of computer simulation to study tumor growth. Demicheli is an MD, PhD. He did a lot of work with animal models, and he said that the best description he can come up with for an animal model of tumor growth or a cancer cell becoming developing cancer and a lethal cancer, it starts off as a single cell that can remain in that dormant state for a variable period of time. Once it starts to divide, it gets to a point where it cannot get much larger until angiogenesis kicks in. And that's another period where you can go through a dormant phase. And then once the angiogenesis kicks in, this tumor can grow to a detectable size and a lethal size. So this figure describes our collaboration. I was going to use my computer simulation skills to study the Milan database using Demicheli's growth model and try and understand what those two peaks were. Next slide, please. Okay, this is the what I found from that computer simulation. These are data superimposed on the premenopausal patients. That 10-month peak corresponds to patients who had dormant avascular micrometastases when they were discovered, and the surgery caused the angiogenesis, and it took 10 months to go from a dormant avascular micrometastasis to a detectable tumor. That 30-month peak is representative of what happens with single dormant cancer cells that at the time of surgery, something caused them to escape dormancy, and they showed up as relapses 30 months later. So these first 3 years, these are iatrogenic actions, that something happened at or about the time of surgery to induce angiogenesis or single cell activity from dormant states. And that peak at 60, 70 months is more or less the natural history of disease. And that's sort of when you first get the benefit of surgery to remove metastases, potential metastases. You can see here that the surgery-induced activity is a very large part of the problem. Next slide, please. Okay, this is a figure that was very influential to me when I was trying to understand those first peaks in Demicheli's data. This was a paper published by Smithers in 1968. This was a case of a 16-year-old boy who had an osteosarcoma. And in those years, in the 60s, this was a period of time when physicians could do nothing. They could just do watchful waiting for months at a time before they had to intervene. And in this case, Dr. Smithers was expecting that this osteosarcoma would come up as a relapse in the lung of this 16-year-old boy. But he was interested in what's going on. So he did nothing other than take x-rays of the lungs of this boy for 7 months. Nothing happened for 7 months. At 7 months, he first saw some activity in the lung, and then he followed that lung tumor for another 12 months before he removed it. The really interesting thing to me was that 7-month time when he first saw that metastasis appear, that's exactly when they did the amputation of that leg of that boy. So this raised questions. What was this? Was there a coincidence? Did the amputation just happen to have when the metastasis first showed up? Or did this amputation cause this metastasis to start to grow? This is good evidence. It doesn't say how often it happens. It could happen 1 in 100 times, or it could happen 99 out of 100 times. But it looks to me like this would be a very difficult thing to explain as a random case of happening, that this is a coincidence. I don't believe in coincidences. I think this shows that yes, surgery can cause metastasis. It doesn't show how often it happens, but it does show that yes, it can happen. So after I saw this figure, I felt justified in using surgery-induced angiogenesis and single-cell growth into the Milan data. And that's how I came up with those 2 early relapses that I say were surgery-induced, that the surgery-induced activity, as demonstrated by the Smithers paper, can explain that. Next slide, please. Putting this in quantitative fashion, this early dominant peak are 2 previously unreported relapse modes that are surgery-induced. And one of them is the 10-month peak is mostly prominent for premenopausal node-positive patients. It was 5-to-1 node-positive to node-negative, and 2-to-1 premenopausal compared to postmenopausal. And that 30-month peak were previously inactive single cells that were induced into division and then stochastically vascularized. It turns out that this is a very, very large effect. Looks like 50 to 80% of relapses in breast cancer are iatrogenic, and they show up as these 10 and 30-month peaks. The magnitude of those 10 and 31 peaks increase with tumor size and the number of nodes positive. That late peak after 50 months, 50 to 200 months, is more or less the natural history of the disease. And as I said before, the benefit of surgery to reduce metastasis first appears at about 5 or 6 years. Next slide, please. I've looked at a lot of cancers and different cancers of different parts of the body. And if you look carefully, and my eye is pretty calibrated to seeing these bimodal relapse patterns, you can see it in almost every cancer. I don't think there's any cancer I've looked at where I haven't seen that. Pancreatic cancer, melanoma, lung cancer, prostate, on and on. If you look carefully, these are either case reports or large databases, but I can see the same pattern in all these cancers as we reported in the breast cancer. Next slide. Strange thing, I was looking up a paper in a book, and I ran across a paper that I didn't expect. This is a paper by Irving Ariel. He did a historical review of breast cancer treatment, and he looked back at what Celsus and Galen did. These are 2,000-year-old situations, ancient Greek and Roman scientists and physicians. These comments have been translated through several languages, so I can't guarantee that the exact wording is the same. But Celsus said, first there's the cacoethes. Cacoethes is not used anymore. It's a term not used anymore, but it relates to small but obvious tumors. They haven't gone through the skin or anything like that, but you can definitely see there's a tumor there. So SALSA says first there's a cacoethes, then carcinoma without ulceration, then the fungating ulcer. Fungating means the tumor has gone through the skin. And SALSA continues, none of these can be removed, but the cacoethes, the rest are irritated by every method of cure. The more violent the operations, the more angry they grow. After an excision, it recurs, bringing with it the cause of death, whereas at the same time, by using no extirpation, protract lives, notwithstanding the disorder to an extreme old age. Gallen says something very similar. They have often cured this disease in the early stages, but after it has grown to a noticeable size, no one has cured it with surgery. This is very similar to those figures I was showing you in the past, prior slides. The Milan data and the Fisher data. Okay, this is such a large effect. It should show up if you know what to look for. And we've done a good amount of examination, and there are 4 clinical topics where we can say that these clinical topics can demonstrate what we're talking about in unexpected ways. First of all, adjuvant chemotherapy works really well for premenopausal node-positive patients. Published a paper in 2004, and co-authors are Gianna Bonadonna, with 30 years of working on studying breast cancer chemotherapy, and Judah Folkman, I was on Folkman's staff at the time, and Folkman spent 30 years doing angiogenesis research. So the explanation that I came up with that the surgery causes angiogenesis, and that's a very proficient, very strong growth right after surgery, and that's why chemotherapy works particularly well for the premenopausal node-positive patients, because that's when you get the most intensive growth right after surgery. That's when Bonadonna found that chemotherapy is best administered. And the second item is that mammography works better for women who are postmenopausal than those who are premenopausal. When they first were looking for the benefit of mammography, they were sure it was working, but they wanted to see what the magnitude was. So they did clinical trials in the US, UK, and in Sweden. And when the results came out, they found, looking at the postmenopausal women, there was an early appearing and strong 20% mortality advantage for the women who had mammography. That was reasonable, but then when they looked at women in the 40 to 49 year age, they found an anomaly. In the first few years, starting at the 3rd year of a clinical trial of mammography, there were more mortality events among the women who had the mammography than those who were the controls. This caused a lot of confusion. People didn't like the answer. This became known as the mammography wars. At any rate, Dema Kelly and I were writing a paper. The paper was about to be published. And at one of the Folkman lab meetings, a reporter from the Wall Street Journal, Amy Marcus, this was a very rare situation. Folkman did not like reporters, but he got to know Amy Marcus, and so she was invited to one of the Friday morning lab meetings in the Folkman lab. And just as a conventional discussion, she happened to find out that Dema Kelly and I were about to publish a paper in about a week describing the fact that mammography works better for women in their 50s and in their 40s. And this could be explained by what we're saying is that surgery causes metastases to occur. So Amy Marcus wrote a report in the Wall Street Journal, came out. On the day that paper was published, that report by Amy Marcus in the Wall Street Journal came out, and Harvard issued a press release. And as you might expect, this got a lot of attention. One thing that was really important, we got a letter from a physician, a surgeon who was originally a Nigerian native, Isaac Gukas. He was working at a hospital in UK, And he wrote in this note to us, it said, this could explain what happens in Nigeria. In Nigeria, women typically find a breast lump in their 40s, mid 40s, and they know what's going to happen. They've seen it so often that women who have surgery will relapse early, but if they don't have surgery, they'll live longer. So in Nigeria, when women find a breast lump, they go to an herbalist to get some soothing ointments rather than going to a surgeon to get a mastectomy. This got a lot of attention from our group. Something is going on here, and it seems that in Nigeria, something is more dramatic happening among the Nigerian population compared to the US population. Third item, turns out the racial disparity in outcome, that in the US, European Americans have an advantage, a survival advantage compared to the African Americans of about 1.5. There's a 1.5 excess mortality for African Americans compared to European Americans. This was not explainable, but these data that we first were learned about from Demicheli and Isaac Gukas, it seems to be the same thing. There's an inversion at age 57. Women who are African Americans that get diagnosed under age 57 have poorer outcome compared to European Americans. But if the African Americans are diagnosed over age 57, they have a mortality advantage. So it's hard to explain this on some socioeconomic issue. It's got to be biological. And from our perspective, that was a good information because I would rather work on something trying to solve a biological problem than a socioeconomic problem. And this fourth item is that it's common that breast surgeons can discuss cancer in young women as aggressive. Well, from their perspective, they remove a primary tumor, and in about a year, the tumor comes back as a relapse, and it acts aggressively from their perspective. But from our perspective, this is clockwork relapse at about 10 months after surgery. Next slide, please. So the most important finding at this point is that we knew that something seems to happen at or about the time of primary surgery to cause these early wave of relapses that account for over half of all breast cancer relapses. Surgery causes angiogenesis of dormant avascular micromets and starts growth of single dormant cancer cells. And this may be a general effect, not just limited to breast cancer. Next slide. Coming forward to June of 2010, this is an unexpected situation. We saw a paper published by a Belgian anesthesiology group, Patrice Forget et al. This is a retrospective study. They have to expose all the residents in anesthesiology to all the drugs given in anesthesiology. What they did here was that Forget looked at the last 315 patients, consecutive patients who were operated upon by one surgeon at this hospital in Brussels, and looked at the outcome of these patients, but grouped them by what drug was given at anesthesia. And a big surprise was that one drug seems to, by far, show better outcome, lower hazard of relapse in that first peak. What was I going to say here? The ketorolac is one of the NSAIDs that's available as IV. There are 3 NSAIDs that are available as IV, but at this time in this hospital, only ketorolac was the only NSAID that they had. So they didn't look at the other NSAIDs. But ketorolac seems to have a very big impact on reducing these early relapses. And this is a very good clue to us maybe inflammation is what's causing these early relapses. Next slide. These are quantitative analyses of the Forget data. There was a five-fold reduction in relapses in the months 9 to 18. Next slide, please. Okay, at this point, we knew that something at the time of surgery was causing the problem. We didn't understand, we didn't know what mechanism could be that. So we did a very coarse examination of these very large subjects: surgery, inflammation. Inflammation is occurring after surgery because there's a surge in IL-6 in the serum for about a week. Angiogenesis, platelets are sequester angioactive factors, and platelet count decreases after surgery, and VEGF increases by about 10% after surgery, which says that angiogenesis is active in that first week post-surgery. It is known that cancer patients have circulating tumor cells, and the immune system is compromised after surgery, and cancer dormancy is well known, and neutrophils are generated in large numbers after surgery. Something's going on here, and I'm quoting from two papers here, Balkwell et al. Inflammation is not the spark that causes genetic damage, but it's the fuel that feeds the flame. And Igawa was looking at capillary permeability in the presence of inflammation, and it increases in size of a particle that could be passed through the capillary walls from 30 to 70 kilodaltons to 2,000 kilodaltons. So there's a big improvement in permeability of the capillaries, and some of these things are involved. Next slide, please. Okay, I'm going to show you five mechanisms that could explain these data I've been saying. First of all, this was a paper, this out of chapter 4 in that Springer Nature book, Hiller, Shire, and Rydell. Reading chapter 4 in that book, I would be surprised if surgery did not cause cancer to start growing or cancer to spread. These neutrophils to cellular traps. Neutrophils in certain situations can expel some DNA material as they're going through the capillaries and the veins. And these are gooey things that can form like nets, like butterfly nets or fisherman nets. They can capture circulating cancer cells in the capillaries, and neutrophils have the ability to extravasate into tissue. So you can imagine that neutrophils generated in large numbers for a week or so after surgery can capture circulating cancer cells and drag them into tissue through these expanding extravasation leakage. Okay, so that's the first mechanism. Next figure, please. This was a very important mechanism. Creel et al. Published in 1918. The laboratory director of the Creel group was Robert Weinberg. So Weinberg knew quite well what was going on in this research, and they did an experiment. They developed an animal model, a mouse model, where they can inject cancer cells into this mouse. And if the immune system was intact, these cancer cells would go into dormant states, but only if the immune system was intact. But they can do an experiment. See, my colleagues and I can do a lot of analysis of data, but we can't do an experiment. In this cancer model that came out of Creel et al., they found out they can operate on this mouse at any place, and you can get tumor growth at another place. And this could be controlled by using a perioperative NSAID. So this is a mouse model. It's not the same as a human model, but it's an experiment, and we can't do an experiment. This got a lot of attention. MIT issued a press release, and this was reviewed in the New England Journal by Komarov et al. Next slide, please. This was chapter 8 in that Springer Nature book, Marie-Louise Bonelike-Berndt. They worked with an animal model, the zebrafish model, and they could color, the zebrafish is a semi-transparent animal, a fish, so they could wound this fish and color code neutrophils and watch to see what's going on through the skin of the fish. Neutrophils are directed to the sites of the wounding, but then they get diverted to pre-neoplastic cells that start to divide. So that's another mechanism by which neutrophils could be involved in causing relapses. Next slide. Next slide, please. Mechanism 4 coming up. This was the fact that, as I mentioned before, platelets actively sequester angioactive factors, and then they degranulate in the presence of inflammation. And platelets decrease by about 10%, and VEGF increases also by about 10%. So you can well imagine that this mechanism could cause the relapses to show up, at least surgery-induced activity. Next slide. Okay, this was a paper published by a Harvard group. I happen to know 3 of these people. This is a high-quality group. Vikas Sakatmi was a co-author of one of the papers with me, and Deepak Panigray was one of the persons I knew from the Folkman lab. First sentence in their paper, cancer treatment is a double-edged sword. Surgery, chemotherapy, and radiation can induce tumor dormancy escape and metastatic activity by impairing some immunity through inflammation-mediated growth signals and loss of resolution of inflammation. So that's it. There are 5 mechanisms that we know of that could explain these data. I happen to like that first mechanism, but I wouldn't be surprised if all these are active. Next slide. Okay, let me skip this one. Next slide. Conclusions, the early relapses, which are the majority of relapses in breast cancer and probably other cancers, consists of surges of angiogenesis and single cell activation. They're triggered by primary surgery that causes systemic inflammation that lasts for about a week. And this inflammation causes exits from dormancy of single cancer cells and avascular micrometastases. So, and there are a number of mechanisms, but it looks very much like this is what's going on. Number 2, data suggests that the transient systemic inflammation is the precipitating factor. It results in angiogenesis and single cell growth and dormancy. Forget data, retrospective data suggests that perioperative NSAID ketorolac reduces early relapses 5-fold. This has not been tested. This still needs to be confirmed. This might reduce breast cancer mortality by 25 to 50% at low cost and toxicity. Low cost, this is a $5 drug given once in a patient's history. And it's not toxic. I had shoulder surgery a couple weeks ago, and I asked the anesthesiologist to give me some of that ketorolac, and I can tell you there was no toxicity whatsoever. Matter of fact, it was a non-painful surgery. The other item I would say here is breast cancer. It runs its course in over a decade, but it seems that most of the events that lead to relapse seem to occur in that first post-surgical week. And this suggests that metastatic progression is amplified 100-fold during that post-week surgery, post-week period. Next slide. And judging from that Fisher graph, it looks like 10% of the N = 0 patients and 85% of the N greater than 12 patients have surgery-induced relapse. This could very well explain why mammography is valuable. If you can just reduce the surgery-induced relapses, that can make a big difference. A second retrospective study was published by Desmet and McKelly in the New England Journal in 2018, accompanied by an editorial. At Beth Israel Deaconess Medical Center, Ketorolac is given to all patients, all breast cancer patients, just after surgery. The patient is still on the table, but before they close up, they give the patient the Ketorolac. That's one way to prevent bleeding, which is a common problem that surgeons complain about if they use an NSAID before surgery. There are a number of retrospective studies underway and for a variety of cancers, and there's one clinical trial underway in Japan for lung cancer. And I got to say, at our point in time, our primary interest is a clinical trial in Nigeria, and a crisis is apparent. Next slide. Okay, these are my colleagues, the upper left corner. I'm standing in the back, and in front of me is Rick Rogers and Pat Wood. Pat Wood died of cancer a couple of years ago. She was a medical oncologist and married to Bill Reshevsky to her left. Bill was my medical oncologist. I was diagnosed with stage 3C colon cancer in 1994, and Bill was my medical oncologist. I was on what apparently turned out to be the first case of metronoma chemotherapy, and that Bill's left is Romano Demicheli, and then above Romano is Benuccia Valagusa and Gianna Bonadonna from Milan. To the upper right, Patrice Forget. Beneath Patrice Forget is Vikas Sakatmi, and this is Isaac Gukas. No, Harabor, sorry. And to the lower right is Judah Folkman. Those three gentlemen sitting at a table. And the lunch table is Michael Baum, Isaac Gukas, and myself. This was at a time in London where we were having dinner there. We're having lunch at the Royal Medical Society. And Isaac described a time in Africa when there was a publicized debate between Isaac and herbalists on what's the best way to treat cancer. You could imagine something like that would never happen in the US. And lower left is Ted James from Beth Israel Deaconess Medical Center. Next slide. I've been to Nigeria 3 times in recent years. These are a few of my Nigerian friends. Next slide. Okay, there was another paper that was published also in 2020. It turns out that this surgery-induced activity is not only for cancer surgery, it's for general surgery. And I published a paper in Sensors in 2020 saying that patients who are survivors of cancer and have some cosmetic surgery or health-related surgery should also take this perioperative ketorolac because they can have a relapse generated by surgery that was non-cancer related, but just the fact that they were survivors of cancer. Next slide. These are the data from that paper where they looked at relapses after a delayed reconstruction. This is from a country in UK, in Europe, Scandinavian country. At any rate, when they set time 0 equal to the time of surgery, they found that bimodal relapse pattern that we've talked about before. But when they set time 0 equal to the time of reconstruction, reconstruction was variable time for from a number of months to up to 3 years. When they said time zero equal to the time of reconstruction, they got that huge surge in early relapses. That says that patients who are survivors of cancer and have cosmetic surgery, after all, a recurrence post-reconstruction is cosmetic surgery, and they had relapses within 3 years of surgery. So they would benefit from the use of ketorolac. Next slide, please. Thanks for your attention. I'll be happy to take any questions. You can email me at michael.retzky@gmail.com.
Thank you, Dr. Apologies, Professor Michael, for an insightful talk, and thanks for sharing your contacts. In case anyone would want to send questions at a later stage, but if there's anyone with a question at this stage, if you could just indicate, please on the chat or unmute to ask direct questions to Professor Michael.
Yes, I have a question. Thank you, Michael, for your presentation. My name is Robin Maddox, and I'm from the United States. You mentioned on slide 18 in regards to, you compared the social impact versus the biological. I'm trying to read my chicken scratch. I was trying to write it down real fast, but with Black women, okay, and your findings. Could you just briefly just take a few minutes, because I think I know I missed something in that, because knowing that there are some psychosocial issues that do affect women, and there's like some connection of dots here that, you know, from my understanding that when we talk about Black women and breast cancer.
Yes, good point. I didn't mention it, but I'll go into some more detail. We were studying this impact after we got interested in that Nigerian data. We were looking at African Americans, and there is an excess mortality in breast cancer for African Americans compared to European Americans of about 1.5. But that only works if the African American is young, premenopausal. If they're over age 57, then the African Americans have a superior outcome compared to the African Americans. Let me say that again. Over age 57, African Americans have superior outcome compared to the European Americans in breast cancer. So just looking at those data, it seems like this could fit in well what we're seeing in those data from Milan, the data from Nigeria. It could be that this is an effect that you might expect to see, that surgery can cause relapse, and it's more prominent for African Americans, and it seems to be more prominent for those from Nigeria. This is interesting situation. This is not the solution, but we're showing this, and we wrote a paper, several papers, saying this could be more evidence to support what we're saying. This is interesting information, and it's not resolved yet, but it's an interesting situation that is part of the experiment here. Thanks for that question.
Thank you very much.
I don't know if that would be all. Is anyone else wanting to ask a question? Doesn't look like we have any questions. Thank you so much, Prof. Michael. And we're going to be moving on to our final speaker of the day. She is Ms. Robin Shine Maddox. Don't know if I'm saying that correctly. And she is from the US, I believe. And her title of the talk is Detours Towards Destiny. We look forward to hearing what the talk is about. The title is quite exciting. So the floor is yours.
First of all, I would like to thank you and the committee, the conference committee, and all those who are participating in this much needed conversation talking about breast cancer and the pathologies and that women and men, are experiencing. So I just want to take this moment first to say thank you. As introduced, my name is Robin Shine Maddox. I'm from the United States. Be a little bit more specific, from the city of Philadelphia and the state Pennsylvania. I just want to share with you, not from a medical healthcare perspective, but I want to share with all of you who are watching and listening in regards to my journey, having been diagnosed with breast cancer and now having recovered. Ironically, yesterday, I just had my follow-up with my oncologist. So I'm really happy to report that I am cleared. I'm on my way to being fully recovered, if you will, from breast cancer. And I'm so excited about that. So I want to speak to all of you who are listening about my story, my journey, as I mentioned, and just talk about as a patient, my detours towards destiny. So I want my conversation is a little bit different than those who came before me, because I want to bring the human experience, of course, my experience, and hope that anyone who's listening will be empowered and inspired as they walk through their journey. In addition to the medical providers, the researchers who are focus on breast cancer and finding a cure, that being even more welcoming and understanding of the person who has been diagnosed. So we often hear that life is a journey, and on this journey, we often find ourselves familiar with, the daily roads, the roads that we travel every day. However, there are times when we travel down those familiar roads, unbeknownst to us, we are now directed to another route, detouring us to an unfamiliar road. The only assurance we have is that along this detour, there are signs and flaggers pointing us in the direction, leading us to the road we were once familiar with, en route to our destination. With seatbelts tightened and moving at such a speed of caution, we begin to take final concession. We're giving in to what we cannot control, yet with the anticipation, hoping that we'll get back on track. So as we're traveling down this detour route, we notice various sights and things along the way that perhaps we did not know existed because of our normal tendency to travel our familiar road. We see now, as we're on this road to this detour, we see new housing developments, parks, shopping malls, business districts along and environments that we did not know exist before we got on the detour, right? So as we're now sightseeing along this detour path, our minds begin to wander with questions, and our emotions taps us on our shoulders as we hold tightly to the steering wheel with our eyes steadfast, looking to see where this detour road connects us back to our familiar road. A familiar road where we can now exhale, relax, a road of normalcy. Well, as we all know, our lives come with twists, turns, and yes, detours. So it was back on February 26, 2018, I was suddenly shaken by the news that a lump was discovered in my breast. After having to go back for a second mammogram, it was the 3D mammogram that exposed that lump. Now, at first, it was not uncommon for me to have a second screening since, I had that before, but the results were always good. It always turned out well. But this time, when I was scheduled to return back for the results for the 3D screening events, I thought to take my mom. Once my name was called and I was told to step on the scale and my blood pressure was taken, inside, I then knew that this wasn't going to be the way that I was so accustomed to, and something must be wrong. The doctor met with us and shared the news. Robin, you have breast cancer. So I sat quietly, looking at her in her eye, listening intently, taking in every word, holding back my tears. I guess I wanted to tell myself that I'm a strong woman, right? Yet inside, my thoughts and my emotions were having a field day. She thoroughly explained the tumor and the next steps. She said that the tumor was hidden and had to be removed ASAP should it would spread even further. After she explained, I, being a woman of sound faith, I immediately grabbed her hands. Tears began to stream, and not commenting on to her explanation, but I asked, "Can I pray for your hands?" And she agreed. And so I prayed. Following that prayer, I said, let's schedule the surgery. Now, one can not imagine the mental turmoil racing through my mind. When and how will I be able to tell my daughter who was away at college? How would I tell my friends, my family? Now my faith is being challenged. Thinking, how is this going to impact my daily lifestyle, my work, my social life, ministry, eating, sleeping, upcoming events that was already on my calendar to be scheduled. Those who know me here, they know that this news was not going to stop me from or having a severe impact on what I am accustomed and what I do, my work, my social life. But yet, I found myself frozen. So much was going on during that time, after all, being the person that I am, and so specifically engaged, as I mentioned, and planning events, the whole 9 yards. The doctor told me that it came back and she gave me the date for the pre-admission. Well, this was interesting to me because the date that she scheduled my pre-admission, the day before, I was picking up my daughter from spring break. So can you imagine how in the world do you tell your daughter, a college student who is so excited about her academic life, in addition to she was just accepted to pledge a sorority, right? And so now the tension even heightens because here I have a situation, a serious situation that's going on with me in my life, right? And then a daughter who is so excited about college and being accepted into a sorority, about to be accepted into a sorority. And I had to wrestle. I wrestled with that. It caused a lot of tension within. But somewhere deep down inside, I just knew because of my resounding faith. Somewhere, I didn't know how, but I knew that this was going to work out. Yes, I thought about my own mortality, right? But then there's a purpose in the pain and the detours of our lives, right? So going through the operation, My family, of course, is aware. They're by my side. My friends, my employer, my coworkers, all supported me through my journey. So during my treatments and recovery, I began to change my why me, this is not fair, what did I do to deserve this, thinking and shifting to how I can use my situation to help, inspire, and offer hope to others while in this very moment, this season of my life, not knowing who or what, how things would turn out. How can this situation be used to bless and encourage others? Is that even possible? I've begun to think while I'm laying on my bed of affliction. Now, physically, I was exhausted and in pain, discomfort. Emotionally, I was torn, worried, and more concerned about my daughter and my family. However, spiritually, my faith began to settle. I began to feel strong, experience the strength. And I concluded, yes, even in my detours in life, I will embrace it. And I decided that I'm going to see where this will lead me to and how this will lead me to my destination. What may not make sense, upending my norm, causing us to shift gears suddenly, can eventually be used to work for us and not against us. Now, no, I'm not saying to ignore, suppress, pretend that the diagnosis and the treatments, that it didn't exist. But what I am saying is, how can we make our lemon, you heard the saying, out into lemonade? I want to just encourage those, again, who are listening, that there is purpose for the pain. And you're probably listening saying, ma'am, I don't quite think so. You don't know what I'm experiencing. You don't know, our situations may be similar, but yet, there may be some differences. So how can this pain be used for a greater purpose? Well, I'm glad you asked, because in pain, you will discover how strong you really are and how God, the Creator, will grant you the strength you need for every step of your journey. Your past creates a platform. That's how I saw it. My pain, all of a sudden down through the years, and as the minutes and the hours and the days and the months were unfolding as I was going through this journey, little did I know a platform was being created for me, as well as for you, to propel you forward with courage and the ability to inspire, help, and offer hope to others while experiencing what you are and what I've been through. Now, detour, there are purposes, right? Purpose, what I call purpose opportunities while we're going through this detour, right? For me, many doors of opportunities have been extended to me. Connections, new connections, valuable information and resources for me that allowed me to share with others, just like this conference. Hearing from the dynamic speakers, now I can go back to my communities, those who are in my reach, that I can share the wealth of information that will bring hope and inspire others who are diagnosed with cancer. That yes, you can, in the midst of your storm, in the midst of your pain, that there is opportunities for you to encourage and inspire not only others, but to inspire yourself. So how could that be? How do you do this, Robin? Well, again, I'm glad you asked. Be transparent, share your story. Your story may not be the same as others who you're sharing with, but I guarantee you, right, that there is something that you can connect with someone else and others can connect with you as you share your story. Be transparent. Be an informant, right? Share the resources, the medical breakthroughs, right? The findings, right? Be an advocate. Connect with your elected officials, attend support groups, use social media as we are today, right? To share information, to encourage one another. Be engaged. Don't run from, but I want you to run to. Engage your family and friends as you process and walk out your journey. Don't forget to laugh. Don't forget to smile. Yes, you can be active. Lastly, I would encourage you, be you by embracing you. Get past the shame of your looks. You know, I was one of many who lost my hair. That was devastating. I'll never forget that Memorial Day weekend. I am combing my hair, and as I'm combing, my hair was just shedding. Not only shedding, it was just coming out completely bald. And I cried. It's okay to cry. I began to feel shame. What will people think? How am I, even my own self-thoughts, right? But then over time, I had to turn that around and tell myself, it's not the hair that defines you. It's who you are on the inside. So I say to you, whether you lost your hair, your weight, or you lost weight, the changing of your skin, the scars, even yes, if you are one who had to have a mastectomy, allow the inner you, the real you, to shine nonetheless. No shame, all shine. Find your light and shine. Shine your light brightly. And just in case, because there'll be times, just in case your light gets dim, or it flickers, or it goes out, quickly strike a match, light a candle, and go on and shine. So I experienced so much support and love, as I mentioned, from so many people. Life continues to go on, and I decided I'm going to live in the moment. As a result, as I was talking earlier about a platform that was being built in the midst of my pain, who knew? Who knew that I was asked just to be interviewed by major newspaper public here in the state of Pennsylvania, in the city of Philadelphia. And a reporter came to my house and wanted to talk to me about my journey in regards to breast cancer on a larger scale, healthcare, and the impact of, when we talk about legislation, and how does it affect people who are diagnosed not just with cancer, but all kinds of diseases, and the importance of making sure that our elected officials and those and others related, they understand the impact and the importance and the value of everyone having health care. Another platform, an opportunity that was presented, I was in 2019 a recipient here in Pennsylvania of the Pink Ribbon Award presented by the Pennsylvania Breast Cancer Coalition, and which now, some years later, I now serve on their board. And here's something else I want to share. When I talk about letting your light shine, you shine in the midst of your darkest hour. It was in 2019. During the end, nearing the end of 2019, and I'm still recovering, that I had enough strength, and a thought came to my head. And I said, you know what? I want to bring together a gathering of women to talk about not just breast cancer, right? But talk about healthcare, health and wellness, the importance of social justice, right? And spiritual enrichment. And I gave birth to a conference, which is now called She Shines. So excited about that. Hundreds of women came, and I thought that was going to be just a one and done conference. But guess what? In 2021, I was asked, Robin, you need to do it again. and bring back the professionals, right? Bring together the gathering of women. Share your stories. Let the women share their stories, right? Let the women, the professionals come in and talk about healthcare, how we can protect ourselves, and what medical information that we need, updated information and research so that we can maintain our health. So you see, no matter what the adversity, challenges, or laws, God continues to keep his promises. He is there with us through it all, whether you believe him or not. He takes our messes, the messiness in our lives, and we can turn it into a message. You know, the testing of our faith, the challenges that we experience, especially when we talk about breast cancer, right? He uses that test and he turns it into a testimony where we can use our adversities and life's challenges to offer hope and inspiration. So in closing, don't wallow, if I could share, if I could encourage all of you, don't wallow in your pain, but search for your purpose and walk in it. Let your light shine. And for those who are not experiencing any pain in your life, your life you haven't traveled down a road, a detoured road yet, right? I would just also share with you, right? Provide the comfort and support to those who have found themselves on a road, the detour road, who are in pain. Share with those who have survived your pain and how you're walking through it. Remember, there is a purpose in your pain. With pain, there is a birthing of something. There is a blessing in the pain. As you go through it, grow through. Go through it as you are growing through it. Yes, take whatever medications that is necessary for the pain. Just don't pity your pain. Just like giving birth, for those who have given birth, we got to buckle down, push, yell, scream, but push through it. And remember, give yourself and allow yourself the time to relax, to rest, recover, and be refreshed. So I end by sharing this with you that came to me as I was going through my journey being diagnosed with breast cancer. And I say to all of you, our strength counters our weaknesses. Our faith soars above our fears, and our victories champions our defeats. Thank you for this opportunity, for this time for me to share with you my journey as with breast cancer and the things that I've learned. And not only that, the pain that I experienced, but allowing that pain to create a platform to empower, to inspire, and to offer hope to so many people. Thank you again.
Wow, thank you so much, Robin, for sharing your journey with us. And congratulations on testing negative, and we wish you well and a long life. We've come to the end of our journey with regards to this particular conference, and I would like to specifically thank all our speakers. Thank you so much for your contribution. And just a couple of announcements. The videos of all our speakers will be available on the YouTube, and you will be receiving your certificates of attendance on or before the 5th of April, 2022. And the UCG is hosting the 10th MRIs and Digital Pathology Conference in May from the 9th to the 10th. Please be on the lookout for that and register. And it's been an honor and a privilege to co-chair with Dr. Ali Po on this particular conference. I hope you guys enjoyed and you were able to learn a lot. And thank you for your time and thank you for your attendance. Have a great evening. The conference ends.